and to our faculty. I don't see all the participants that we saw yesterday, so I think we are still waiting for the rest of them to join. So welcome to Mamala Neocon online sessions for the critical care monitoring workshop. Yesterday, we had some very good talks by overseas and national faculty. And today we have another overseas faculty with us, Dr. N.B. Soni. Kiran, do you want to?
Yeah, sure, yeah.
Yeah, Dr. Soni is a senior attending physician in the neonatal unit, Sidra Medicine, Qatar. Previously, he was a neonatologist as consultant in the Lancashire Women and Newborn Center. So he is currently the neonatal respiratory lead at Sidra Medicine with special interest in PPHN and DPD, pulmonary hypertension management, and also in difficult airway management, which I'm sure a lot of us would like to hear about. He's also senior member of neonatal hemodynamic group, Sidra Medicine, neonatal audit lead. He's has several awards to his credit, and we are indeed very fortunate to have him with us. He will be talking about predictive analytics in neonatal monitoring, hero, comet, and future of AI in neonatal vitals tracking. I think a lot of new terms. Hope he'll introduce us to the ABCs of monitoring. So over to you, Dr. Soni.
Sure. Dr. Soni, just 30 seconds. I'll just go over the agenda, if you don't mind, for today, and then we'll start. But welcome, Dr. Soni. Thank you for accepting the invite. And this is, as Dr. Shambhala said, it's a very interesting and new topic. And as this course is designed, we are trying to cover the basics also. Some of the basics we have covered, lots of basics we have covered about the blood pressure, saturation monitoring, saturation trends, etc., and monitoring during transport. And now today we're going little advanced, as Dr. Soni will be talking on this predictive analytics use of AI, followed by needs monitoring and its interpretation in NICU by Valerie Chalk from Stanford. Then non-energy cardiac output monitoring, which I'll be speaking on. Then Dr. Khurshid Mohammed will be talking on advances in the neonatal neurocritical care. And last but not least, Dr. Karthik Nagesh will be talking about telemonitoring and current status and future directions. And then a lot of the summary of these talks and basics will be covered on the day of workshops, which is 5th of December, which is a physical workshop in person in Chennai in Apollo Children's Hospital, followed by workstations, which will be covering all practical and hands-on sessions, which will be taught in these sessions. So with that introduction, I'm stopping, and over to you, Dr. Soni. You can share the slides.
Thank you, Kiran, Dr. Shamla, for your kind invite. Sorry, I could not make it physically for this workshop in Chennai, but hopefully we'll do it some other time. Let me share my slides and see if you can see. It says sharing is not turned on. You can request multiple presenters sharing on this webinar. Send request.
Yeah, I've allowed you now. Yeah. Now you can share.
I might have to re-log in some. So for sharing, I'm going to, it's not like a shared screen type, is it?
No, it will be.
Share.
Yeah, we can see now. But
no, but that's not the one. 1 second. Stop sharing. So in the share. Okay, here, this is the. You can see now, yeah?
Yeah, we can see the slides. Perfect. Thank you.
You can see the full screen as well, yeah?
Yes, yes. You're live. Thank you.
Okay, perfect. So thank you very much for the invite. I'm going to take through some of the basics of the monitoring, what is currently available in the market, and where things are going. So this is our beautiful Sidra hospital, you can see. So what is the purpose of monitoring? You know, the purpose of monitoring is, can we do something on this side of the screen? Let me get the pointer. Okay. Is the pointer visible?
Yes.
Hi, Kiran. Yeah.
Yes, yes.
Is the
we
arrow
can.
visible? Okay.
Yes, yes.
So the purpose of monitoring is, can we use the available monitoring we have on NICU on this side of the screen effectively, so that we can pick up the patient early and we don't end patient on this side with multiple things. For example, this patient being on ECMO and renal therapy, you know. So can we prevent? We will not be able to prevent all, but if we use monitoring effectively, maybe we can prevent some of the children becoming very sick. So the scope of this presentation is HI and AI. So what I call HI is things that can be used more efficiently in NICU by the clinicians, by our human intelligence, that's HI. And what a machine can give us the alerts, or what it can give us the support in our decision making, or it can give some scores. I call that as the artificial intelligence. Yeah. So in this talk, the areas where the AI is evolving in neonatology one was automated FiO2. You would have heard from my colleague, Dr. Sanoj, yesterday, as to how the ventilators are using the various algorithm to keep the oxygen in target range. So I will not touch upon that. I'll be talking about the hero monitoring for the early detection of sepsis. I'll talk about the COMET monitoring for prediction of the shock and early intubation on deteriorating patients. Talk about what is there as a commercial platforms like etiometry, which is successful in prediction for weaning of the inotropes, extubation failures, and our in-house Sidra, where we have developed the concept of something called as Aspire, and we what it means and how we are trying to take that forward. So these are the areas I'll try and cover. So first of all, for AI to work in practice, you know, there are few things which should be the working. One thing, the science must be understandable to the day-to-day clinician. If the day-to-day clinician doesn't understand that, then they will not buy in. Secondly, whatever you implement, the day-to-day workflow on the unit should not be impacted greatly. It should not change the workflow, because if that changes the workflow, then it becomes very time-consuming. Engagement should be there at all the levels, from the juniors to the seniors to the managers to the CEO of the hospital. And the education should be tailored accordingly to the clinical role, and hospitals should have a culture of encouraging the AI to work. For the things to lead a clinical action, the information, whatever we are trying to get from AI, must integrate into the clinical care. You can't have the AI sitting separately and the clinical care running separately, then it will not be real time. And there should be periodic and support interactions after the formal implementations at the regular intervals, so that the people, when they have the doubts and things, that could be cleared. So these are the essential things for AI to work in practice. So in the first next 7 to 8 minutes, I'll talk you through about the human intelligence. What can we do better with currently what we have? So first of all, we all know that there is a patient monitor and how we should be setting up our patient monitor. This is very basic, but I think it's important to go through it. So obviously there is the ECG and invasive blood pressure monitoring. There is a pre-ductal, post-ductal saturations. There's a respiratory rate monitoring. This is the end-tidal CO2 monitoring. And what I would also recommend that one uses the heart rate either from the arterial source or from the saturation source as the second heart rate. And then one should have what we call as the perfusion index, which is the, so that you know that when the perfusion index, when it is normal, then your saturations are reliable. Otherwise, whatever number you are going to get there may not be reliable. So this is the pre-ductal perfusion index, and this is the post-ductal perfusion index. And the normal value is 0.4 and above. So if you are having a value of less than 0.4 or less than 0.3, then those saturation readings are not reliable. So the perfusion index may be low because of either the probe is not in good contact, or the baby's perfusion is overall low, and therefore the readings are not reliable. But one need to make sure that these are something you tell your nurses, that if the perfusion index falls below 0.4, please reapply the probes. Then at least you get your reliable reading, and then you can make your interventions based on that. So for example, on this one, you can see this is a one of the patient monitor, which is set up with a 2-hour trend on the this side. And here you can see this is the patient with a persistent pulmonary hypertension. You know that when the blood pressure was falling in this over this 15 minutes, the saturations were lower. As soon as the intervention was made for blood pressure to go higher, the saturations got normalized. And when again the blood pressure fell, the saturations fell and blood pressure went up. So even without knowing that from the echocardiogram what pulmonary pressures one has to aim for, you know what blood pressure one has to maintain to keep the saturation up. You don't need the echo pulmonary pressure all the time, because you will have one-off and it's a dynamic thing. So one should be able to adjust by looking at this monitoring. Something similarly there in this one as well. When the blood pressure is low, the sats are low, and as the blood pressure increases, the saturations have increased. And this is from the Philips monitor showing the similar one. You know, pre and post ductal saturations both increasing with the increase in the blood pressure, and both dipping with the decrease in the blood pressure, kind of thing. So something which we can use from day-to-day monitoring, but key thing is importantly to be aware about how to use the setup and how to use them in the regular practice. Now, for example, this is the real time monitoring screenshot I had taken from one of the patients. So this was a 31-weeker. You can see this baby has got both pre and post-ductal saturations lower. The blood pressure is lower. But what else can you see? Obviously, this is not an interactive session, so I will not get any response. But can you see the stroke volume variation you have got on this arterial wave trace? So whenever one has got so much of stroke volume variation, that implies that there is a lack of fluid. There is a volume. So this patient can do with volume. And in fact, in this patient, we gave 10 mL per kilo fluid volume, and the patient's blood pressure improved, and these waveforms normalized later on. And you can see, because the blood pressure is genuinely low, your perfusion index are also both of them very low. And therefore, those saturations are also reading lower. So once we had given the fluid bolus, everything improved on this one. So this is something one should constantly watch out for, the waveform characteristics of the blood pressure. Now, current monitors also allows to take various histograms. For example, this is a 24-hour heart rate histogram. It tells you in the 24 how much has the heart rate varied. So it varied from 100 to 175. Most of the time it was between 125 to 150. For the 1/3 of the time, 30% of the time, it was above 150. Now, sometimes you may see that heart rate is over 200, or heart rate is in the 75. So whether there were significant bradycardias or tachycardias, one can objectively see that. Something similar, you can do the respiratory rate histogram from the monitor, and that will tell you how much baby has remained tachypnic over the last 24 hours or 12 hours or 8 hours, because these are all customizable. You can see as a 24 hours, you can see as 12 hours, 8 hours, 4 hours. So one can review this in the ward round and make more objective decision what to do. Again, this is about the arterial systolic blood pressure, what it has remained, over the last 24 hours, and what has been the diastolic blood pressure kind of thing. Because when your resident or fellow presents you, they present you the current finding. How do you know what exactly happened in the 24 hours? You will get the information by looking at these things. Something similar is pre-ductal saturation histogram, post-ductal saturation histogram. But as I explained to you earlier, how do you know these histograms are reliable? So to make these histograms make any sense, you can do the perfusion index histogram. So this is the perfusion index of pre-ductal. So it tells you that most of the time, in fact, below 0.4 was only probably around 6%. The rest of the time, the signal was pretty good. And same thing was, but here if you see in the post-ductal, below 0.4 was 21%. So 20% of the time, the signal was not that great, So if you get, say, for example, 70% of the time signal is not great, then you can't really act on that histogram. So I think these are useful things to see in concordance kind of thing. Something similar, I'm just giving a snapshot because I can't cover everything in 25 minutes. So for example, one can look in the ventilator's bedside. For example, here, if you see, this is the flow diagram. Inspiration, expiration, inspiration, expiration. But can you see that there is so much of a gap between inspiration and expiration, and the I time is set as 0.4. So on your bedside, you can use your human intelligence to interrogate this and decrease the I time. This patient does not need 0.4 as the I time, irrespective of what your blood gases show, so that the patient is not exposed to the barotrauma. Something here, another screenshot from the Draeger ventilator. This is on the high frequency mode. You can see that this is the trend of the volume, and this is the trend of the DCO2. So DCO2 will tell you how your carbon dioxide is going to behave and how things have reacted. So if you have a, say, 24 hours trend, you will be able to see what exactly has happened in the 24 hours. So one should always set up the monitor and the ventilators correctly to see the things. This is another mode of the high frequency ventilator in Fabian ventilator, where when you want to recruit the lung, there is a technology called as a FOT technology, force oscillatory technique, where the ventilator can actually tell you and plot that at what different increase in the pressures, how curve you are going to get. So if you are going to get a beaked curve, then you don't need to go to that pressures kind of thing to recruit the lung. So you need a smooth sinusoidal curve. So again, these things are available. It's a matter of knowing these machines and implementing with our human intelligence. So, for example, on this one, this was another.
People can chat, Dr. Soni. If you want to ask question, they can write the answer in the chat box.
I'll take it at the end, Kiran, because otherwise my talks has got quite a few slides, so I might lose the thing. So maybe the questions, I think if it was live, it would have been easier, but here I will find it difficult to collect the answers, and because I have to go from full screen to the other screen, it will not be feasible.
No. Chat portal, you will have a chat portal will have a, chat portal, they can type their answers in the chat box.
Okay, chat portal, but I can't see chat portal and the full view at the same time,
Okay, fine.
Okay, so for example, say in this is a patient on a Draeger ventilator. This is on an oscillator mode, as you can see. Now, can you see anything wrong in this thing, and what was done from the screen 1 to 2 to 3? Yeah, this is the same patient, and something was changed based on the graphics. Now, if the graphics are not visible, I'll zoom it for you. Wait a second. Okay. So I've zoomed the same graphic. So this is the graphic, what was there. Is there anything wrong you can see? You can see that there's a pressure which becomes a negative here. You should never get a negative pressure in an oscillator. Yeah, it should always be above the line. So when it happens below the line, this is called as a choking point. So if you see a choking point, that means your ratio of the mean airway pressure and the amplitude is not correct. Now, this patient obviously needed this much of amplitude. And when we looked at the X-ray, it was a suboptimally expanded. And that is the reason you were getting the choking point. So what we did, mean airway pressure was 11. So we increased to 12. So what happened then when we increased to 12, the choking point decreased compared to that, but there was still a choking point. So we then increased further. We increased to 14, and you can see the choking point had disappeared. So now the risk of air trapping has disappeared. So unless you see these things, you will not be able to apply at the bedside. So that was about a snapshot of, I got lots of examples, but I could only show you a few. That was about how you can use your human intelligence by the bedside to make things better. Yeah. So I will now switch on to something different. What is currently there as artificial intelligence in the neonatology world? So one of them is use of the heart rate characteristics. So the signature of health is that the heart rate slows down during expiration and it speeds up during the inspiration. Now, we may not see that because the heart rate is continually displaying, because it's beyond a human naked eye to constantly keep watching. Even if the nurse is sitting there, they can't watch the heart rate slowing and increasing with the inspiration and expiration. But that is an important variation which should be there in a healthy person. And this loss of this signature, the loss of this variation, means something wrong is going. So that is the whole concept about this. So based on that, so this is the normal heart rate. If you plot, so this is a heart rate plotted over against a time. You can see this is normal variation, what you get over a period of time. Yeah. So, and here you see that there is no variation. The heart rate is almost like a flat line. Yeah. Heart rate will be there, but the variation will not be there. And here, if you see, there is a too much of decelerations kind of thing. And if you zoom, this is how you will see these records. So all these three are abnormal, whereas this is normal. Yeah. So based on this concept, they developed something called as a hero monitor, now which is used for diagnosis of the sepsis kind of thing. So in one of the studies by the Delos in 2011, they could show that hours prior to the diagnosis of sepsis, so this was 150 hours prior to the sepsis, heart rate variation was normal. 6 hours before, can you see there is a less variation compared to that one? Still some variation is there, but it's less variation. But see 3 hours before the sepsis, lots of decelerations leading to this type of graph. So if we were to diagnose at this stage and give antibiotics, obviously the patient, we are catching the sepsis early, and this patient will be prevented from going into the septic shock. So this is based on this is what they developed something called as a hero monitor, which is a heart rate observation. Hero means it's a small abbreviation for heart rate observation. So abnormal heart rate characteristics is an early non-invasive warning for an illness, as I explained earlier. The hero score is displayed here. This is the 5 days of the trend. And this is where the heart rate is captured and analyzed for the variation, So this is a 30-minute trace, and this is a continuous moving trace you will see. So if you have a workshop, somebody will be able to show you this one. And this is the number what you get, so this is number-based algorithm kind of thing. So on this one, but you need minimum of 4 hours to get the first number. So when you attach this monitor, you need 4 hours before you can get any number. And the score, then this variation in the background is computer is converting into a score. So the score varies from 0 to 7. 0 to 1 being 0 to 2 being normal. Anything more than 2 is abnormal. Higher the score, more the abnormality. Or immediately raising by 1. So if it was 1, it is risen to 2. Or it was 0.8 has gone to 1.8, that is also abnormal. So for example, in this studies, they showed that when the sepsis was suspected, so this is the confirmation of sepsis at 0 hours. So this is one before that, and this is after the confirmation of the sepsis. So on this axis is the clinical score, and on this axis is the heart rate characteristic score, which is the hero score. So if you look at the one in circles, the clinical score is in the circles here, and the squares is the heart rate characteristics. Can you see the heart rate characteristics about 12 hours before? So this is days, so 0 day, -2 days. So this is -1 day. So almost 24 hours before, or certainly 12 hours before, the heart rate characteristics changed, whereas the clinical characteristics did not change as much. And the peaking was earlier. And after the treatment, it came down. So what it means is, if your heart rate hero score is 2, this means there's a 2-fold increased risk of sepsis. If it is 3, it means 3-fold increased risk of sepsis. So anything which is more than twice, which is more than 2, is taken as abnormal. And if there are no other reasons, I will go to the next slide, there could be other reasons for that as well. Then you do the septic screen, take blood cultures, and start the antibiotics so that you can catch the sepsis early. So in this study of the one published in the pediatric research, they enrolled almost 3,000 very low birth weight infants. So in them, there was the late onset septic episodes were 974 in 700 infants. So 23% had sepsis. And they randomized them into the hero monitoring display and non-hero monitoring display. Yeah. So this is the randomization they did, and they did what can they can the hero monitoring be better than the non-hero monitoring? And what they found, so this is a graph of the survival. So if it's decaying down, that means number of patients are dying. So if you look at the solid line, that is the hero line, and the dashed line, that is the line of the standard monitoring. So whether it was a con sepsis or a gram-negative sepsis or a fungal sepsis or a gram-negative sepsis, you can see there was a better survival of the patients who were monitored by the hero compared to the standard monitoring. So on the forms of sepsis, those who were allocated to the hero monitoring, their survival was better compared to those who were not with the hero monitoring. Again, if you see that days to septicemia, so the solid line is the heart rate characteristics, the dashed line is non-heart rate characteristics. At the time of diagnosis of sepsis, can you see the hero score had increased significantly almost 2 to 3 days before and peaked, whereas on the standard ones, the risk factor based ones, it did not. And you can see here that the days to septicemia, the heart rate characteristics peaked early, and this is very significant. So another study where they again enrolled about 5,900 patients, and after excluding, they randomized 3,000 patients to the hero arm and to the non-hero arm. And finally, they analyzed roughly 1,500 into each of them, So basically, in the study group, they used this monitoring screen, and the non-study group, there was no monitoring screen. They were going by clinical assessment and the risk factors. And again, you can see those which had a heart rate characteristic monitoring and the conventional monitoring, the survival kind of thing was much better in the heart rate characteristic monitoring compared to the conventional monitoring. And if you look at the risk percentile, the fold increase in the risk of sepsis, it becomes almost like when the score becomes 2 or more, there's 80 to 100% chance of that patient having a sepsis kind of thing. But obviously, if the score is lower, then the risk of sepsis is lower. And hence, in the hero, they say the score of more than 2 is something, a magical figure where patient has to be assessed for the sepsis and then a screen for the sepsis if it is felt to be appropriate. Again, the hero monitoring and the conventional monitoring, you can see in the very low birth weight infants. So number needed to treat to avert one death in the very low birth weight was 48. In extremely low birth weight, it was 23. So this is a normal hero score because it is less than 1. There is no variations. You can see. Is there somebody asking something? Hello?
No, I think I don't know from. Okay, okay, 1 sec. Yeah.
Is
Dr.
there any
Karthik
issue?
Yeah. There was somebody's accidentally open. Yeah,
Okay,
that's okay.
that's fine. So this is a normal hero score. Here you can see that the hero scores have had the septic hero score got risen here, and here you can see this kind of variation. So this is a 5-day screen. So when you get a hero score like this, patient need to be assessed as the first thing. Then you need to find out whether it's a false positive elevated score or whether it fits with the clinical sepsis. So we'll go through that in the subsequent slide. So this baby obviously had a Klebsiella sepsis in the blood and the urine. Again, this baby did not have a sepsis, but this baby had a NEC. And again, the scores in the NEC can be raised. So the fact that when the hero score is rising, is asking you to make the assessment of the patient. Patient may appear well at that point, but you need to look for the subtle signs. And that is what this hero score is doing. So in summary, infants whose hero heart rate characteristic monitoring results were displayed had a 10% more blood cultures drawn. So the people will be worried. So every time the score goes up, we'll be doing the septic screen. So we'll be doing a lot of blood cultures and a lot of antibiotics. But obviously the blood cultures were only 10% more, and only 5% more were on the days of antibiotics, was not significant when they compared with the standard kind of thing. So it is, yes, you will end up doing some more blood cultures, but you can stop at 48 hours. Yeah. But the duration of the antibiotics is not that much from that perspective. So again, the similar results, just summarizing that in the very low birth weight infants, those who were randomized to the HRC monitoring, where the results were displayed, had a lower in-hospital mortality. 8.1% compared to 10.2% where the HRC was not used. And this was more significant when it came to the extremely low birth weight babies, where the difference was even more. And this I already covered, that you needed a number needed to treat for 48 for VLW and 23 for the ELBW. Now, if it was that simple, everybody would have used a hero monitor. So it isn't as simple as that. It obviously helps, but there are reasons for the elevated hero score. So if the baby runs constantly tachyarrhythmias, then your scores can be raised. If the baby has got a complete heart block, then your scores will be raised. If the baby goes through any anesthesia or surgery or ROP examination using anticholinergic medications or IVH, those babies can have a falsely elevated scores. Caffeine obviously does not impact, but otherwise these are the reasons where score could be elevated. On the other hand, we may miss the sepsis if we solely rely on that, because if the babies are on steroid, then the inflammation is minimized kind of thing. So babies who are on postnatal steroids, we may not pick up. So if the patient is clinically ill, you investigate regardless whatever is the hero score. But if patient is well, and if the hero score is raised, do have a low index of suspicion to screen so that you can catch the sepsis early. There's one thing which we have been studying, and that is that there are a lot of false positives we are observing on the neonates who are in a respiratory support, specifically the NIV. I don't know why, what is the reason behind that. We are going to investigate that. But I have seen lots of patients where patients are otherwise well, but the hero score is constantly going up and down when they are on the non-invasive respiratory support, something which we plan to investigate further. So that was about the hero monitoring in brief. How much time do I have, Kiran?
Probably 5 more minutes, 5-7 minutes. Yeah.
Okay, so I will probably rush through the others. Yeah, because hero score is where you got the most used evidence, but there are other couple of things which I will just touch base upon. So one of them is called as a comet. The comet means this is an abbreviation for continuous monitoring of events trajectories. So this is a something like Hero. In fact, the same people who did Hero, they are now doing the Comet as the another AI platform. So what basically this is a it basically is based on the analysis of the ECG waveforms, various electronic medical record vital signs, lab data, and the patient events which clinicians input so as to diagnose 12 hours before the true clinical deterioration. And this is being tried in the PICU and CICU for the early detection of sepsis, cardiogenic shock, respiratory failure, and early need for the intubation. Currently, this comet has been acquired by the Neocon, which is one of the monitoring systems in the NICU. So just to go through the couple of studies kind of thing. So in this study of the 50 unplanned intubations they had, so which was in the surgical ICU patients after the surgery, they use this multivariate predictive model. So in this comet, it's not just the heart rate, it's the heart rate, respiratory rate, saturations, the mean blood pressures, the respiratory and saturation correlation coefficient. They are all used in making the in the decision making kind of thing. So here, based on the comet scores, they were able to identify the babies who need the early intubation kind of thing, and it displays as the risk from 0.2 to 2.95. So obviously, higher the score, more the chance of intubation. So rather than doing unplanned intubation, one could go towards the planned intubation, because you know that these babies will be requiring the intubation kind of thing. And obviously, if the previously baby had the extubation recently, then if you add that factor into account, then it increases the further sensitivity from that perspective. So for each patient in a critical unit, the Comet monitor assigns a comet-like icon, which I'll show you in the next sign. That's why it's also called Comet, because of that reason. And it will show the fold risk from 1 to 5 for the future critical event. So for example, here, if you look at this graph, so along the x-axis is the cardiovascular instability, along the y-axis is the respiratory instability, and here is the time axis from this point of view. And these are the patient bed numbers. So you can monitor the total number of patients and display on the center monitor. So the darker the comet, the thicker the comet, more the risk. So if you look at it here, the darker comets are first three, and they are more thicker. So 93, 94, and 97 patient number, they are basically at a higher risk from this point of view. And in these ones, those which had the higher and thicker comets from the cardiovascular stability point of view, one of them ended up in a hemorrhagic shock and required 3 blood transfusions. And one of them, from the respiratory event point of view, needed the intubation as documented by the alerting physician. So this is how, again, the comet can be used. So on this one, for example, the patient number 93 is selected from the previous one. And here you can see the patient's comet score as a function of time. So the scores is from 1 to 5. Yeah. And you can see over a period of time as to what is happening with the scores. So if the patient, you can see the green, this is rising. So that patient is deteriorating, and comet is becoming more thicker over the last 3 hours from that point of view. So again, that gives you an instinct. This patient is going towards the respiratory failure, or whether it's going towards the cardiovascular shock failure. So it can be predicted from that perspective. Again, something similar in the patient number 91, the comet, which was thinner before, but over the last 3 hours, it became more thicker. And that patient was, the scores was going more, the comet was heading more toward the respiratory instability. And this patient ended up needing the intubation kind of thing. So if you see these signs and you ignore them, then they will crash in a heap. So better to get the right people to assess the patient so that they can be taken care of. So the difference between HERO and COMET is obviously both are used for the sepsis, whereas here is for the unplanned intubations as well in the COMET. Here only heart rate characteristics are used, whereas in the COMET it's a lot of things are used: heart rate, respiratory rate, SpO2. The correlation between the heart rate and the respiratory rate, the heart rate and the SpO2, the respiratory rate and the SpO2, the apnea burden, the periodic breathing burden, and the abnormal characteristics of the heart rate, what happens, So here you get a risk of sepsis only, where here you get risk of sepsis plus the respiratory and cardiovascular deterioration kind of thing. So COMET is a much advanced system compared to HERO, but it is mainly tried up in the PICU and CICU. NICU trials are just coming up, far and fewer, but HERO is quite well established in NICU. So watch out for the space in coming years on this COMET studies kind of thing. And the last, I'll take probably 2-3 slides. Last is what we call as the etiometry. Now, this etiometry is a platform which is, again, similar to the COMET platform, but here it takes even much more things into account. Again, same lab data, patient events, various patient monitorings, and also takes the ventilator data into account, and it comes up with a variety of pathways. So for example, etiometry started in 2010 and was used as a clinical decision support software earlier. But now variety of studies have been done in the PICU and CICU showing that with the use of the etiometry, they could decrease the ICU admission or a ventilation time or vasoactive infusions or length of stay, or the satisfaction by the nurses that it decreased their workload. So these are the current pathways in development in CICU and PICU. In the NICU, the extubation guidelines pathways has come into play in 2023. So I'm sure more and more papers will be coming, and also the extubation readiness test has been rolled out. So I'm sure more publications will come out in the future about that. I will not go into details, but of lack of time. But what this was one of the very big retrospective review in the pediatric ICU, where they showed how the weaning of vasoactive inotropes can be achieved using the algorithm on the etiometry platform, using what they called as the mixed venous saturations less than 40%, that is inadequate oxygenation of the tissue algorithm. So when they used this one along with the laboratory data, they were able to see which patients were suitable and which were not suitable for the weaning. For example, when they used in the patient A here, so what they used was when the inotropes was getting weaned, they used the last 6 hours to see what was the oxygen score on that one. And then they used 6 hours after. So here, this was a successful patient, whereas on patient B, when they used it, the dopamine was discontinued, but had to be restarted few hours later. And if you see here, so this was the IDO2 score. So here it was felt that IDO score was low enough to wean and stop the inotropes kind of thing. But within few hours, the score started rising, the red thing started rising, and the dopamine was restarted. And you can see the score has started to come down from that perspective. So a lot of very complex and things are coming which can help in our decision making. Again, something similar. This is the IDO2 6 hours before the weaning of the inotrope. So if you see this pattern of weaning, this pattern of the IDO2 score, you're not going to wean the inotrope because that will be leading to the failure of weaning the inotropes. And the last but not the least, something which around COVID times, Kiran was also involved. We were working on this platform called Aspire platform to get the real-time data. But with the COVID times, we didn't have the right support mechanism, so we couldn't take it forward. But the concept is that whatever we use in the NICU, everything feeds into the central data flow system, and that goes into parallel server and put them on a physiological x-axis and y-axis, be it a cardiac output monitoring icon or NIRS or a Draeger or any other ventilator, Philips monitoring blood gas, infusion pumps, and the clinical events, and see what is their correlation. We are restarting again with new funding application. Let us see how far we go on that, but that is something which we wanted to develop as well, to come up with something similar to etiometry. We wanted to develop. So in summary, my realistic view is artificial intelligence is evolving. It will take time to reach NICU because most developments are currently focused on CICU and PICU. More and more newer versions of equipments are coming with attached AI. For example, ventilators are coming with attached AI like automated FiO2 or automated recruitments. So integration of all the patient monitoring devices, we are far away. It will at least take another 5 to 10 years. But while that is happening, can we use our human intelligence to its maximum while AI is evolving so that we can best use what is available to us, as I showed in the first part of my talk. Thank you very much, and happy to take some questions. Sorry, I overran by 5 minutes.
Sure. Thank you, Dr. Soni. Again, excellent overview. Lot of things will be new for many of the attendees. But again, it's just to stimulate what is there and evolving. And as Dr. Soni said, stick to HI, stick to basic. One question Dr. Shamla asked was specific. Is it hero specific for the sepsis only or any other illnesses? So I think mainly it's a sepsis prediction, right? Yeah.
It is more about the inflammation. So, for example, as I showed that in NEC also, your hero score will go up. So it will give you a warning. But as long as you are sure that the baby is, that's why for me, hero score is an alert sign to go and see the patient and see where it is. If the patient is on just a NIV support and otherwise completely well, tolerating feeds, nothing is happening, then I would probably ignore that hero score, but keep a close watch. Because we have seen that a lot of patients are getting the false positive hero scores when are on the non-invasive respiratory support. But if otherwise, if patient has got some tummy distension or a feed intolerance, better to suspect the early NEC and treat from that perspective.
Right. And that question was international or local validation. You did share some studies already. Is it validated? That's the question again. How
it is validated in PICU and CICU setting. In the NICU setting, there are only the couple of pathways being rolled out through the COMET and the etiometry. So they are not yet fully evolved. So this is a fertile ground. Obviously, anything, it takes time to come to NICU. It comes to adult world first, then PICU, CICU, and then NICU. So I think it's a fertile area for people to work in NICU. In fact, we were hopeful that we will probably get the COMET and CIDRA. I don't know what was the final outcome, because it depends on which monitoring system you're going for. Because if you're going for neon coded monitoring, you will get a COMET as a subset of it, Whereas if you're going for Philips, you will get more histogram oriented things.
Yeah, some more questions again, reliability, movements. So there are movement artifact, but basically simple movement should not affect because it's a cumulative score prior to the, so it takes some time to generate that score. So movement artifact is the question.
Again, as I said, the movement artifacts, there's a filtering of the data which happens in the background because they look at the PI, if your saturation index things, then they look at the PI, the perfusion index, and they do have a signal filter in most of these new monitors. So if the signal is less than 80%, they exclude that data.
Yeah, so maybe you can sum up like all these monitors. If you have it, then maybe use it as an alert to go and see the baby. You still take clinical decision. Don't jump onto those monitors and take decisions. But if something is alerting, machine is alerting, go and check. Because many places nurses may not be that competent. Maybe the machine might alert you earlier. So I think that's what the take home probably at this stage, isn't it?
Absolutely. Our jobs are still safe for next 15 to 20 years, not to worry. Yes. And this is a fertile ground for people to do a lot of research. So AI is not going to replace our jobs. It's not as much as people talk about. Yes, it will evolve. It will evolve, but probably it will take a long time to come to the neonatal world.
But we should be aware of it at least. Yeah.
Absolutely. And we should embrace the technology, because I use it all the time. All the histograms, monitorings, I use all the time, and it definitely helps me.
Sure. Thank you, Dr. Soni. That was enlightening. Lots of new terms and new information for most of the delegates. So thank you very much, and thank you for your time. Excellent talk. If you're happy to stay back,
Thank
but
you for inviting.
at the end we might put, but if you can log in later on at the end. Okay, thank you.
Sure. Thank you.
Sure. So moving on to the next session, we're a little behind, but hopefully we'll catch up. So the next session, we have a very eminent speaker, Dr. Valerie Chalk. Thank you, Dr. Valerie, for accepting the invitation to be part of this workshop. She's a professor of pediatrics and neonatology in Stanford University, Stanford, USA. She's a chief clinical research in the Stanford, and her expertise in NIRS. So there's nobody else I thought of asking for NIRS, and she's got a grant and a program running for NIRS over which began over 10 years ago, and a lot of NIH funded trials are going on. So somebody who has got hands-on clinical experience plus research experience and a subject matter expert. So thank you again, Gallery. Over to you. I'll stop sharing and you can share your talks. She'll be talking to us on NIRS in neonatology.
Great. Thank you so much, Dr. Curran. Let me just share my screen. And really, it's a pleasure to be here to speak with all of you. And 1 second. Okay, can you folks, let me just double check. Do you see the first slide there?
Yeah, full slides, yes.
Yes, it's good? Okay. Wonderful. All right, well, I'm very happy to talk about one of my favorite subjects, NIRS or NIRS monitoring. And I have nothing to disclose. Okay, so let me just, okay. So there are many physiologic monitors that we're familiar with in the NICU, but up until recently, end organs like the brain have been forgotten. And we feel that monitoring using NIRS is one important monitoring device, there we go, that I'd like to talk about that I think is a really critical component to knowing about a baby's full comprehensive health. All right, so we're going to review first monitoring tissue oxygenation with NIRS. And some of you may already be familiar with this technology, but this is just a brief review. NIRS or NIRS is a continuous, real-time, non-invasive bedside monitor of regional tissue oxygenation, which is often abbreviated RSO2. This technology is validated with jugular venous saturations, and in the US is FDA approved for use in even the smallest babies. So we routinely monitor our 22, 23-weekers with NIRS. It works in principle very similar to a pulse oximeter, where near-infrared light is emitted from a sensor, passes through the underlying skin, bone, and soft tissue to a depth of about 2.5 centimeters, and there it's differentially absorbed by oxygenated and deoxygenated hemoglobin. The light's then reflected back to detectors on that same sensor, and a tissue oxygen saturation is calculated, which reflects a ratio of the underlying arterial and venous blood. So it's heavily venous weighted, about 75% venous, 25% arterial, and also shows us the balance between oxygen delivery and consumption. So at our center, we like to recommend two-site NIRS monitoring, and the reason for that is that circulatory impairment will reduce the somatic saturation first, and so that's an earlier indication of hemodynamic compromise. This may be if the baby's autoregulation, cerebral autoregulation is relatively intact. That's why the brain may be a later finding of change. So here you see a cerebral sensor on the baby's forehead. Sometimes it's challenging, especially on our preterm babies, to place it only on the right or only on the left. So we go with whatever is available. And then for a somatic location, we tend to use the renal site, where a renal sensor is placed on the posterior flank to the left or the right of the spine, below the costal margin and above the iliac crest. And we have done studies to determine using ultrasound that this indeed reflects blood flow to the kidneys, as well as obviously surrounding area. Some centers also do mesenteric saturation monitoring. I'm not going to talk about that today, which will look at oxygenation of the intestines, but typically this is done more in a research setting. Okay, so let's review what to do when we have abnormal values. Large population-based studies were conducted, and you see there on the left, what's considered a safe zone in green is roughly between 55 to 85% for cerebral saturations. This is based on large population norms with 2 standard deviations above or below the mean. We also did a study looking at outcomes, and similarly, on the right, you can see that the percentage of time with the cerebral saturation less than 50% was associated with mortality or severe IVH. So again, this kind of 50% borderline range, and below that, there being potential problems, both from outcome studies as well as population studies. So this kind of gives us our target ranges to maintain. Keep in mind that the ranges in term babies tend to be higher than preemies, and the values may differ. The absolute values may differ by sensor and device type. So it's very important to look at the trend over time for an individual baby, more so than the absolute value. And in fact, animal piglet models looking at cellular ischemic thresholds also kind of confirm these thresholds. So if you look at histologic images from the hippocampus, animals were exposed to a cerebral saturation that when it dropped below 40%, you start seeing changes at the bottom here, some mitochondrial injury and swelling and fragmentation of the Golgi and endoplasmic reticulum. So again, more just cellular evidence that cerebral saturations less than this 40 to 50% threshold can lead to injury in the brain. Just briefly about renal saturation, typically the kidneys run 10 to 15% higher than the brain, although in premature babies in the first few weeks of life, these values may be equivalent or lower than the brain saturations with a lot more variability. And this could be due to the effects of a PDA. We'll talk about that later. Sometimes developmental changes in the kidney or sensitivity of the kidney to hypoxia. All right, so let's think about, this is one of my favorite slides because we have to approach abnormal NIRS values physiologically. And as I said, about 50% is when a provider is notified and should be called to the bedside to really assess the baby and think about what are the factors that can influence cerebral oxygenation. So I'd like to remind people that there are 4 main factors that affect oxygenation of the brain. First of all, overall systemic oxygenation. So is this baby hypoxic? What are the baby's overall systemic sats? Is this a baby we need to turn up the FiO2 on the ventilator? Secondly, cardiac output. And blood pressure can be a surrogate for cardiac output. Is this baby hypotensive, and that's why there's not enough perfusion to the brain? Is this a child perhaps that we should give a fluid bolus to or start a pressor? Number 3, oxygen carrying capacity, of course, is the baby anemic? Perhaps this is a baby that could benefit from a blood transfusion to improve their cerebral saturation. And lastly, number 4 is the baby hypocarbic. Carbon dioxide is a very potent cerebral vasoconstrictor. If this baby is overventilated, it can lead to poor cerebral perfusion. Now, of course, there are a few other additional factors that might play into things that occur less commonly. So I mentioned cerebral metabolic rate. So perhaps this baby would require sedation or is hyperthermic. And then there may be some other underlying conditions which contribute to low cerebral oxygenation values like IVH, a significant PDA, congenital heart disease, or even excessive intrathoracic pressure caused by a pneumothorax or too high pressure from your mechanical ventilator. On the opposite side of the spectrum, you could have cerebral saturation values that are too high. And in this case, too high is typically over 90%, given that this is a very much of a venous weighted measure. So if your values are too high, perhaps the systemic sats are actually too high, and this is a baby you can wean your FiO2. Or perhaps this baby is hypercarbic, which causes cerebral vasodilation, and you may need to increase the ventilator support. Number 3, this baby may not be extracting oxygen very well. So perhaps we're over-sedated or hypothermic and we're not utilizing oxygen. And I'll also talk a little bit later about babies with HIE or hypoxic ischemic encephalopathy whose brains are injured to the point where they're not extracting oxygen. And then finally, there are some conditions with redistribution of blood flow to the brain, like growth restriction or hypoglycemia, where you'll see elevated cerebral saturation values. So let's look at what this may appear like at the bedside. So this is a preterm 27-weeker, 1 week of age. And you can see the cerebral saturation from the NIRS monitor at the top of the screen in blue. And you see that it drops from 70% where the arrow is down to about 40%. So something happened. And as the provider, you get called to the bedside and hopefully think a little bit about this talk, but also about what impacts cerebral oxygenation. And as I mentioned, one thing to consider is your overall systemic sats. So could this baby have been accidentally extubated and be undergoing a severe prolonged desaturation? Sure, this is entirely true. This is something that could explain this drop in cerebral sat. Secondly, what about cardiac output? Could this baby be hypotensive because the nurse is switching out the IV dopamine infusion? This is also a possibility for what could explain this drop. Thirdly, we talked about hypocarbia from overventilation. Maybe this child, the team did not look at the ventilator as closely, and this child may be overventilated. This could have altered the cerebral oxygenation as well. And then finally, this is what truly occurred in this case, anemia. So this baby had a sudden pulmonary hemorrhage and became significantly anemic, which dropped the cerebral saturation. So how did we intervene? We gave some packed red blood cells, and you can see the cerebral saturation comes up very nicely. So obviously we didn't need NIRS monitoring to tell us that the baby was having a pulmonary hemorrhage, but I use this example because it's a very nice way to kind of step through what are the possible factors that could be influencing this baby's brain oxygen level. Now, I wanted to briefly touch on the Safe Boost C3 trial, which was an eagerly awaited large international phase 3 pragmatic randomized controlled trial. And it enrolled over 1,600 babies who were less than 28 weeks gestation, looking at whether maintaining a targeted range of cerebral saturations between 55 to 85% using a treatment guideline would improve outcomes. And what was found was that the intervention group that had NIRS monitoring in place had a lower burden of cerebral hypoxia compared to controls without NIRS. But as you can see by the bar graph, there was no difference in mortality or abnormal cranial ultrasound findings at 36 weeks between groups. So this was, a little bit depressing to some of us in the field, like, oh, we really wanted to see this large study show a difference in long-term outcomes or in outcomes. But on the other hand, I keep telling people we cannot give up on NIRS monitoring entirely. That's sort of like the phrase we use, throwing the baby out with the bathwater. And a few things to think about. Are we studying the right population? Should we focus on all preemies or the highest risk preemies? What about using the right targets and time frame? Because we know the Safe Boost study only looked at the first 72 hours of life, and cerebral hypoxia can occur, far beyond that, and it may even start in the delivery room. We need to focus on what are the best interventions for cerebral hypoxia. What about other competing signals? And then finally, are we tracking the right outcomes? What about white matter injury in the MRI and longer-term neurodevelopment? And the Safe Boost trial investigators are following up these babies now. And so we hope to have, again, kind of look a little farther out in terms of outcomes. And then I do want to mention that we have to be careful about holding new technologies like NIRS to a different standard than other monitoring technologies. So think about pulse oximetry. Pulse oximetry is an example of a technology that was widely embraced despite a lack of interventional trials to establish its utility in monitoring. And even now, there's still controversy over what are optimal saturation ranges to use. But that doesn't stop us from clinically using pulse oximetry. And so similarly for cerebral oximetry or NIRS monitoring, we need to be aware of its benefits and limitations and continue to investigate how it can best be used. So I'm going to use the next part of my talk to really go through a few applications of NIRS monitoring in the NICU where I feel it can be very helpful. So the first situation is in babies with a PDA, which we know is a very common problem in preemies, and NIRS has been used to study the cerebral and somatic effects of a PDA, as well as the response to medical and surgical treatment. So we did a study to predict the significance of a PDA using cerebral and renal NIRS measures in babies less than 29 weeks gestation. And we found that in those babies with a significant PDA compared to those without a PDA, they had lower cerebral and renal saturation values. And in particular, the renal sats were the most significantly associated with a significant PDA. And so here you can also see it in graphical format. Even when we followed babies out to 30 days of age, babies with a significant PDA here in orange compared to those that did not had lower renal saturation values. And in fact, a renal sat less than 66% here on the ROC curve was associated with the PDA with pretty good sensitivity and specificity. So what does this look like at the bedside? Okay, so here we have our NIRS monitor, cerebral saturation in blue, reading in the 60 to 70% range, so not terrible, but look at your renal sats here in white. They're reading about 50%, but there's quite a bit of variability as one would expect with an open ductus. So given these findings and a concern for a duct in this baby, the team elected to treat this child with indomethacin. And you can see even before they got a confirmatory echo that the renal saturations improved significantly to about the 90% range and much less variable. So we know now that at least from an end organ standpoint, this duct is no longer hemodynamically significant. Here's a different baby, again, perhaps 26 weeker, about a week and a half of age. And this baby had a heart murmur and they were concerned about a PDA. But look at this NIRS monitoring. Here you see the cerebral saturation in blue reading in the mid-70s, the renal sat in white also in the 70s, as you can see, even sometimes higher than the cerebral sat. Still with some variability, but a higher baseline. So in this child, we are not as concerned with end organ perfusion, and we did not feel that this duct was hemodynamically significant. So this child was conservatively managed. So this kind of is a good way to show how NIRS monitoring can help us just as to provide some added evidence for whether or not a duct is hemodynamically significant and perhaps then guide what the team may want to do. Okay, so let's move on to a different type of scenario that we can see in the NICU. So this is a 26-week preemie, 2 days of age. And what do we notice from this NIRS tracing? Well, we can see the cerebral saturation again in blue starting to downtrend. And you can see that it's reading in the 40% range, which as I told you earlier is abnormal. So what do you want to know? Well, you get called to the bedside and again, think very physiologically about what affects your cerebral oxygenation. So overall systemic sats looked appropriate. The baby's blood pressure was also within normal range for a preterm infant. Carbon dioxide level was appropriate. And the baby's hematocrit was also okay. So these, four main physiologic principles didn't seem to be affected. Something else was going on. The baby wasn't overly agitated or hyperthermic. Could this baby have a PDA? Sure, the baby's only 2 days old. But what's very curious is that the cerebral saturations seem to be affected more so than the renal sats. So this led us down the path of something else going on. This mom had chorioamnionitis, and the baby was being treated for presumed sepsis. So we know chorio is a known risk factor for white matter abnormalities and impaired autoregulation. So this low cerebral saturation prompted us to get a cranial ultrasound. And unfortunately, this baby was shown to have a bilateral grade 3 bleed. And while this was an unfortunate occurrence, the discovery of this event was hastened because of the low NIRS values being seen. So with severe IVH, you can have low cerebral saturation levels. And the reason for this is thought to be the excess venous blood in the area of hemorrhage, so making it, again, very venous weighted, as well as a lower cerebral blood flow state around the time of a bleed. What is not known is, can we capture a period of hyperperfusion and impaired autoregulation just prior to the IVH occurring so that we can do something about it? And this is where some active research using AI principles as well are underway. Here's another example of IVH. This is a 24-weeker triplet with bilateral grade 4 IVH and ventriculomegaly. And unfortunately, you can see here, the cerebral saturation is barely even picking up. It ranges from between 15 to 50%. There are prolonged periods where the cerebral saturation is less than 40%. Here at the arrow, the baby was transfused some blood, and you see just a very minimal increase in the cerebral saturation. A corresponding AEEG was done, and this is discontinuous low voltage tracing, so kind of confirming poor electrical activity of the brain. So in this case, the NIRS helped with end-of-life discussions for this family. Okay, so that was the summary about IVH. I'm going to shift now to one other common clinical scenario in our NICUs. This is a treatment of babies with hypoxic ischemic encephalopathy, or HIE. And this is a term baby with HIE who is being cooled using therapeutic hypothermia. And we can see here in blue, the cerebral saturations are pretty high, 90 to 95%. So at first glance, a high saturation seems great. But when it's too high, please keep in mind it represents a failure. It can represent a failure of oxygen extraction, especially for an injured baby after birth asphyxia. So this is a study we did as well. High cerebral saturations after 24 hours here is associated with death or moderate to severe brain MRI abnormalities. And you can see that here, the red group is those with adverse outcomes. They had higher cerebral saturations, close to 90% compared to those with normal outcomes. And correspondingly, when you calculate their tissue oxygen extraction, their brains were not extracting as much oxygen. Others have also looked at adverse neurodevelopmental outcomes at 1 to 2 years of age after cooling for HIE. And again, in these small studies, those babies that had adverse outcomes, shown by the white bars, had higher cerebral saturations in the first 24 hours of life. So when you see this at the bedside, this is an example of what it might look like. This baby was a term infant with severe encephalopathy after challenges with his delivery. And you can see the cerebral saturation here in blue. It is pretty flat as well. There's like no variability here, and reading the highest value the monitor picks up, which is 95%. So his brain was not extracting any oxygen. When you look at his corresponding EEG, it had a persistently low voltage tracing, and unfortunately, his brain MRI showed multiple foci of restricted diffusion to the thalamus, basal ganglia, and frontal lobes. So in this way, NIRS would help with prognosis, a relatively poor prognosis for this baby. In contrast, here's a different term baby with moderate HIE, and we say moderate based on his initial neurologic SARNAT exam. You can see his NIRS tracing cerebral saturation in blue, reading in the 70 to 80% range, so normal range with some variability. This baby's EEG showed some mild discontinuity, and in fact, this baby's brain MRI was normal. So again, NIRS can be used to provide some reassurance as well for babies with HIE if the values look appropriate. All right, so I'm going to finish up our case examples with the use of NIRS with respiratory failure. And I think NIRS is very, very helpful in babies that are ventilated. So here's an example of a term baby with HIE who's on the ventilator. And what do we see here? The cerebral saturation in blue with a sudden drop. So we think about what could explain the drop in cerebral NIRS measures, because it's not only the absolute value, but also the trend over time. So this is a significant change. And if you look at the possible choices here, sorry, I didn't activate any kind of polls, but think about what are some possibilities. Could this baby be thrombocytopenic, hypocarbic, hypertensive, hyponatremic? Think about what you would do as a provider if you got called to the bedside. So let me tell you that think about, again, the 4 main factors that influence cerebral oxygenation. The baby is satting well on the ventilator, has a stable blood pressure, a stable hematocrit value. But look at this baby's blood gas. The pH is high at 7.7, and the PCO2 was only 31. So this is an example of hypocarbia, which, as a reminder, is a really potent cerebral vasoconstrictor and should be avoided, especially in babies with HIE. So what did we do at that first arrow? Obviously, if hypocarbia is our problem, we wean the ventilator rate. And in fact, when the rate was weaned to 20, a subsequent blood gas showed a nice correction in the PCO2 to 51. And you can see at the second arrow, a little bit of blue here, the cerebral saturation increased back to the 80% range. Now, we can also see the opposite happening when we're looking at the effects of hypercarbia. And so remember, I told you hypercarbia can cause cerebral vasodilation and higher cerebral sats, which you see here with the cerebral saturation of 93%. And in this baby, going through, if you got called to the bedside as the provider for a high cerebral sat and a sudden change in upward trend, thinking of all the 4 parameters, this baby's CO2 was 90, and that was a reason to make some changes on the ventilator setting, and only after the CO2 was corrected did the NIRS also start to normalize. So a great way to kind of demonstrate, you may not be checking blood gases routinely on this child, but the NIRS is telling you that something is going on, and you need to investigate further. Okay. We're always finding new indications for NIRS monitoring. Here's a baby with gastroschisis with the bowel outside of the belly in a silo. And you can see this baby has NIRS monitoring in place, both for the brain, and also there's, you can't see it, but there's one on this baby's flank. So we're doing renal monitoring kind of as a surrogate for blood flow to the rest of the body. There are some centers that actually place a NIRS sensor on the silo itself to kind of look at what's going on with perfusion to the gut. But this baby was having her bowel being actively reduced, and I think this was maybe about 2 days of age. And the reason why we decided to follow these babies with NIRS, I'm going to show you this example that was very interesting. You can see this is a little bit of a different tracing, but the renal saturations are in orange and the cerebral saturations are in blue. There was a sudden drop in the renal sats, and there's a lot of variability here, again, during this time period when the bowel was steadily being reduced. And so at that time, that's the time where you see the first arrow, the baby was found to have acidosis. The baby's abdominal girth went up by 4 centimeters, and the bowel looked a little bit dusky. The hematocrit dropped to 33%, so the baby was transfused some blood. And here you see a nice response to that. but it was only transient. And then there's again another significant drop, this time not in just the renal sat, but also the cerebral sat. So that it wasn't very stable. And at that point, the baby was taken to the OR and had an exploratory laparotomy done, was found to have really patchy ischemic areas to the bowel and a subcapsular liver hematoma that was causing abdominal compartment syndrome. So in this case, gastroschisis with compartment syndrome, the NIRS monitoring really helped us to early on detect that there was a problem going on. Okay, so I'm going to finish up with talking a little bit more about how to implement a clinical NIRS monitoring in your NICU if you don't already use it. So I think it's important to establish a specific neuro-NICU population, to put in place guidelines for timing and duration of monitoring, thinking about target ranges and interventions that you want your team to perform, thinking about data capture and really what kind of ongoing education is there going to be, because otherwise it's just one more monitor at your bedside that nobody pays attention to unless there really is an effort to talk about it on rounds or in educational conferences, for example. We have a yearly quiz that we ask nurses and attending physicians to go through to really just refresh their memory about how to use NIRS monitoring. And it's all about exposure. We started off with using NIRS as a research tool only. Then we focused it on a targeted population. And now it's a routine neuro-NICU monitor that we have available at every bed space if needed. So here is our targeted population that we monitor with NIRS. These are preterm babies, less than 29 weeks gestation for the first 7 days of life. And the reason why we chose that was just because of the risk of IVH and hemodynamic instability, but also later on if there's a concern for a PDA. We monitor term or preterm babies with congenital heart disease, respiratory failure, babies that are pre-ECMO or on ECMO, and babies with HIE. But really, there are many conditions where you might be concerned about adequate cerebral blood flow as listed here. And again, we keep thinking of newer indications where NIRS monitoring might help us. Okay, so we have a protocol in place where, as I mentioned, two-site monitoring is performed, both the cerebral sensor and a renal sensor. And in fact, in our preterm babies, our golden hour, we have the cerebral sensor that's placed actually in the first 10 minutes of life, even before the umbilical lines are placed. And then the renal sensor is placed just before the top comes down on the baby's isolette. So this is part of our routine protocol that the nursing staff and the house staff are aware of. So it just becomes part of the routine. We have a way to incorporate NIRS monitoring in the electronic medical record. So there is an order set that it's part of. You just check the box. The values pull into our progress notes along with the routine vital signs. And then we have a system for archiving NIRS files for future research studies or QI projects. And it's kind of interesting hearing Dr. Soni talk, maybe incorporating all these data streams together and using kind of like AI. I think that's going to be the way to go in the future. All right, so some challenges to implementation. Of course, NIRS takes up space on the baby and at the bedside. There is a cost involved to the monitor and the sensors. And keep in mind that there can be variability in absolute values between the different types of devices. I tell people to pick one type of device and learn how to use it well. The signal is only penetrates again about 2.5 centimeters deep, so it's limited to the cerebral cortex. We're not measuring deeper structures of the brain. And I think we really need additional research on how targeted NIRS monitoring can improve long-term outcomes. I like to really focus on sensor and skin care, especially if we're using NIRS on our preterm babies. We use a skin dressing like Nepitel so that the adhesive is not bothering baby skin or peeling it off every time we're applying it. We asked nursing staff to check around the sensor site every 24 hours, and we empirically change the sensor at least every 4 days, just so we can rest the skin a little bit, look underneath it, maybe move the sensor slightly when we reapply it. I tell people to avoid direct pressure over the sensor because I have seen pressure injury occur, not burns, because there's no heat generated from the monitor, but pressure injury. And so just be careful if there's like a CPAP device pushing too hard on the sensor. And then people always tell me that, well, the sensor falls off because we're in high humidity in the isolette. And so we have found ways to maintain adherence. Sometimes a loose knit cap and cutting a little slit so that the sensor can come out of the cap. Some of the nurses like to put little bows on the baby. So really there's creative ways to keep the sensor in place. And then I emphasize that NIRS monitoring, it should not be a barrier to holding babies. It's just like any other monitor. Don't make sure parents are not afraid of it. And then obviously, as I said, keeping the monitor in place, how long are we going to keep it there? As long as you think you're using the data and it's clinically useful. Okay, so where are we heading with tissue oxygenation? I think in the future, we'll have smaller integrated wireless sensors. We need to think about other tissue beds or other populations. So what about in the fetal setting? What about in the delivery room? There are many people that have been investigating this. Some of you may heard of the Cascade trial, but there are some ongoing ways of looking at NIRS monitoring in the delivery room to help guide resuscitation. Looking specifically more at kidney, intestine, and muscle, functional NIRS, and perhaps guiding transfusions, as I briefly alluded to earlier. And then finally, as I mentioned, data synchronization and machine learning or AI algorithms for prediction is where things are moving in the future with all of these, helpful predictive measures at the bedside. Okay, so in summary, monitoring of tissue oxygenation using NIRS is feasible in the NICU. NIRS monitoring may be an earlier indication of acute injury than traditional measures and may have clinical utility, particularly as I showed you in premature babies, babies with a significant PDA, babies with HIE or respiratory failure. So thanks very much for your attention. If you have any further questions or if you're interested in joining the Neonatal NIRS Monitoring Consortium, please email me. This is a group that I help to put together where we host maybe like quarterly webinars on NIRS related topics and just provide a forum for people to ask questions about using the technology. Thanks very much for your attention and happy to take any questions.
Perfect. Great talk, Larry. Very practical and example based. Lots of comment and few questions. One is, does hypothermia affect NIRS reading?
Yeah,
You
that's a
covered
great
briefly.
question. Yeah, and just because as people think it kind of like decreases your metabolism, so it will slightly affect your cerebral saturation, but only when people have looked at it, not clinically significant, like maybe only by 1 to 2% may it potentially increase your cerebral sats.
Okay. Also, can raise ICT influence cerebral NIRS readings?
Ah, yes. So what I didn't talk about, so because babies have an open fontanelle, you don't often see that, but in babies with ventriculomegaly and post-hemorrhagic hydrocephalus, some people have started to use NIRS readings to kind of determine, okay, when should a baby go for a VP shunt or, some kind of surgical intervention based on, okay, if there's increased pressure, you're not getting great perfusion to the brain. So yes, that is an active area of ongoing research that I didn't touch on in this talk.
Sure. One question is again, abdominal, splanchnic or renal. So one question, how you are sure that it is renal SpO2 and not intestinal?
Yeah. So that's one of the criticisms of using abdominal NIRS monitoring. And that's why I do feel also with the peristalsis going on, there's often like meconium, people say it may interfere with the signal. So I don't rely solely on like a abdominal or splanchnic NIRS reading. I think it's interesting. I do think that some people use it in addition to other parameters to say like, oh, this baby's at risk for neck. What do you think about it? But that's why our center, we use the renal saturation as a surrogate for what the gut may also be seeing, just because it's a more stable solid organ that the blood flow to the gut, to the kidneys, etc., would be very similar. But there's still people looking very closely at abdominal NIRS measures.
So yeah, so I remember Yasir El Sayed from Winnipeg talks about ultrasound guided NIRS, especially for the splanchnic and NEC. So he is mentioning that maybe you should identify the loop which is affected and try to place
Yeah.
the sensor on that. But as you rightly said, generally the flank, when you put it, that's the renal is a solid organ there, and abdominal, like for the splanchnic, the locations are different, isn't it? So location is one thing and probably might be different. And secondly, use of ultrasound probably might be, I don't know, might be the future. One thing is like, can I detect the NEC early using splanchnic, using NIRS?
Yeah, I like your idea of ultrasound guided, because then you're using all the technologies you have available to kind of like, focus in on what area of the gut would be most affected.
Correct.
Yeah, I think there are some studies, some early studies that have sort of looked at prediction of NEC, and definitely in those babies that have developed NEC, yes, the NIRS values are going to be lower because there's decreased oxygenation to the gut. But the prediction part is still, I think they're still fine tuning it.
Sure. One more is scalp edema can affect NRS, edema
Yeah.
of the scalp.
Yeah, that's a good question. I have seen that, yes, in babies that are very edematous, have high drops. Sometimes the NIR signal does not pick up as well because of the edema. So that could be a potential limiting factor.
Great. And one speaker is one delegate is from Nigeria. She's asking about how to overcome challenge and accessibility and affordability. So I'm facing that. Yeah. Like I've used NIRS in all my previous units, but not in the current. So one way is to get over is to get through a research grant, or maybe a part of Valerie's that consortium. Maybe regularly attend this, and maybe a part of the research. Maybe that's to get research funding. That might be the way to get those devices along with consumables for 3 years at least.
Yeah,
I don't
that's
know,
a great suggestion. Yeah, or talking to the manufacturers. I'm sure they probably want to expand their market as well, so maybe they can help.
Exactly. So they can help out to trial it out for some studies. So designing the studies probably and launching in a big units, that's probably the way forward for anyone who wants to trial it out. We in
Yes.
fact has written recently a grant. Let's see if we get, we will also have it in a unit.
Okay, great.
Okay, thanks, Valerie. That was really great talk. Awesome. And if you can stay tuned towards the end, if there are questions, maybe I'll text you and you can log in and answer. We'll see.
Sounds great. Okay,
So,
thank you.
perfect. Thank you, Valerie. So because we are running over the time, we are just rescheduling a little bit, and Dr. Khurshid Mohammed will be going first before me, and then followed by Dr. Karthik Nagesh. So Dr. Siddharth will introduce Dr. Khurshid. Over to you, Siddharth. I'll just pull up the CV, one sec.
Kiran?
Okay.
Hi, Khurshid.
Yes, Sid. How are you? So
Hi,
good to see
good. How are you?
you. Long time.
One sec. Yeah. I hope you can see the CV for Dr.
Yes, I
Khurshid.
got that. Yeah. Good evening, all. It's my great pleasure to introduce Dr. Khurshid Mohammed. He was my senior and mentor in Calgary. So he's the site head of Alberta Children's Hospital in Calgary, Canada, in the NICU, and he started the neurocritical program there in 2014. And he's also introduced the sonographic clinical assessment of newborn program, the SCAN program, which we have seen so many times in India as well. So his main interests are in innovation in education, quality improvement, and there have been a lot of simulations in EEG, echoes, ultrasounds that he has done in training programs. He has been recently awarded the Emerging Leader in Neonatology Award by the Canadian Pediatric Society. So he's published many articles, many studies in neurocritical care, and his passion is towards development of neonatal neurocritical program. So with those words, I welcome you, Khurshid.
Thank
Over
you
to
so much, Sid. Just share my slides. Can you see it?
Yes, thank you for agreeing to fit this talk in a busy schedule. He's traveling. He's I think in Abu Dhabi right now, right? And only he had a window of these 2 hours for us. So that's really great for agreeing to do this.
It's my pleasure to do it. I'm actually in Saudi. I'm in between
Saudi.
three cities. So that's nice. But it's really a pleasure and honor to be here and present to you guys. My only disclosure, I am not sure that what I will present will be the cutting edge advance in neonatology. Maybe some of them, but certainly lots of innovation and different ways of applying what you have in a creative way to answer some important questions. And it's important to understand where we started from. And Sid will remember when we started our neonatal neurocritical care program, we had no form of brain monitoring, even CFM we didn't have in Calgary. And in fact, they had to cancel one station in one of our practical OSCE exams, the national ones, that had the amplitude integrated EEG because the fellows graduated from Calgary. They didn't have exposure, so it wasn't fair for them to answer that question. So from there, when we started, we were battling giants because there were people like Stephen Miller groups, and they were well established and had lots of publication and setup. So where you go from there, so you will battle those giants when you are this dwarf. And I stumbled upon this book. It's called David and Goliath by Malcolm Gladwell, a very famous writer. He brings the story of David and Goliath, how David fought Goliath. Goliath was very famous and strong soldier that everybody was afraid of, even the tall soldiers, nobody stepped forward. But David was good at slingshots. And Goliath was surprised. Where's your sword? You are very young. How are you fighting me? And the story goes that while he was still talking, that David hit him with a stone in his forehead and he just dropped dead. The point then, he builds the whole book on that. He said, if you are not a giant and you want to battle giants, then you pick an area that giants are not paying attention to. And slowly and quietly fill that gap. By the time they notice you, you will be shoulder to shoulder to those giants. And we did just that. We decided to focus on education and innovation, where all the giants were thinking of the imaging, the EEG monitoring, and the other stuff. They were busy with those kind of publication, where we started focusing on the training and the innovation. So what I'll do today, I'll bring some examples and some of the publication where you can use what you have in an innovative way to help you change the management of babies to better outcome and answer some important questions. Sorry, you can hear my...
Yeah, I've made you host, so you can share slides now. Yeah.
Oh, you see my slides or no?
No, we not yet.
Oh, because I am seeing slide. So
no, I just try to, yeah.
And
share.
How about now? Can you see my slides?
Yes. Yes,
Okay.
they're coming. Yes, we can see them. Yeah, perfect.
So this was the book that I was showing you, and this is the OSCE station. So this is so we'll start by examples. So this is an example of baby we got, was very sick, and was about a month old, or a month and a half, and came with a multi-organ failure. We could not take this baby to the MRI. We always do point of care ultrasound for this baby, cranial ultrasound. And this was the baby's ultrasound. Initial one on the left, it was unremarkable. You can see the choriothalamic notch here and the choroid plexus, the nice cell size and gyri. They are very brisk and nice. And then the next day that we did the follow-up ultrasound, and you can see now there are lots of subcortical echogenicity. So this could be the partial prolonged asphyxia or subcortical white matter injury. And the baby was still sick. we couldn't take this baby to MRI. So we put the EEG on because of the ultrasound, and sure enough, this baby was in status epilepticus, where it was completely subclinical. It was only because of the point of care ultrasound, not the formal ultrasound done by our fellow. And then intentionally, I showed you not perfect ultrasound, because when you put the presentation, you put a textbook kind of ultrasound, but the reality is not like that. And you don't need those perfect ultrasound to answer most of the questions. These are some ultrasound done by our fellows. We have a system where the fellow can upload it to the cloud, and then a staff can access it remotely and give them some directions. So that was a change in practice. Because of the point of care ultrasound, we started this baby on anti-seizure medication, and we were able to control the seizures. It's another example of a baby who came with a sudden drop in hematocrit, and the point of care ultrasound was the reason where we diagnosed a huge subdural hemorrhage. And you can see also here the echogenicity in the subcortical area. Probably this is ischemia. And this was confirmed by the ADC map MRI. And in the ADC, black is abnormal. And you can see in that subcortical, there's lots of black areas, which is ischemia. Plus, there's some intraventricular hemorrhage as well. And eventually, later on, this is a T2 weighted image, that area liquefied and left brain injury in that region. Another example of point of care ultrasound in babies with HIE, for example. This was a case with HIE. We always do point of care ultrasound in babies with HIE. And the hint in this case was there was a profound hypotonia. Wherever you see a profound hypotonia that doesn't go with the rest of that targeted neurological examination, think about brain malformation or muscle atrophy, because this baby was awake, a little bit of lethargic, but the tone was very, very decreased. So we did the point of care ultrasound, showed us this germolytic cyst and some calcification. And whenever you see that in a term baby, always think of the brain malformation. So this was in fact a CMV, congenital CMV infection, and it showed this polymicrogyri in the Sylvian fissure area. You can compare this Sylvian fissure in this area to this one. This one is very thick and it's crowded because of the polymicrogyri. So that was because of the point of care ultrasound. The third benefit of point of care ultrasound is the Doppler. And I think we underutilized the Doppler of the ultrasound for the brain purpose. We are very good at it for the cardiac ultrasound, but not for the brain. And it's an example of a term baby who the neurologists, they were suspecting CSVT, and they wanted to take the baby to MRI early. And because we take the baby to MRI, we don't disrupt the cooling, but they are at risk of the temperature instability because of taking them to the MRI suite and unplugging. But I was able to show them that the sinuses are patent. So this is the superior sagittal sinus, and you can see the flow, blood going through it. And this is the longitudinal image of the superior sagittal sinus. And I was also could show them from the mastoid window that the transverse sinus is patent. So that reassured them, and they were more comfortable of keeping this baby during the period of cooling and send that baby to MRI day 4 to 5 instead. And sure enough, the day 4 to 5, the MRI, this is ADC map again, black will be abnormal. There is no area that's black. So the MRI for this baby was normal. And the MRV also was normal. There was no CSVT in this infant. So can you imagine if we had disrupted the cooling in this baby, this might have impacted the outcome. But it was the point of care ultrasound that saved the day. This is another example of the PHVD. So as you know, the PHVD ultrasound is as good as the brain MRI in echolucent lesions. Those are the cysts and measuring the ventricle. But this was a case where actually MRI helped. So this was a multi-compartment hemorrhage baby we had who developed post-hemorrhagic ventricular dilatation. And we decided to do the MRI because his hydrocephalus progressed very quickly, unlike the usual course of other babies that develop over days and weeks. This was in 24 hours. The ventricles were much bigger because we were doing point of care ultrasound frequently in this baby. We were able to identify that these ventricles went up very, very quickly. And when we did the MRI, this is a T1 weighted image. The blood is bright. You can see all this blood in this area. It was a plug of clot that blocked the aqueduct. So this is your third ventricle, and this is the fourth ventricle. The third ventricle and the lateral ventricles were dilated, but the fourth ventricle was normal because of this plug. And because of this MRI, we were able to convince our neurosurgeon to intervene earlier. Usually they intervene later and they put the reservoir based on the weight and gestational age. But once they saw this, they need to be approached similar to congenital aqueductal stenosis. They put the reservoir in this baby earlier. But the question also comes, who taps the reservoir? And before even tapping the reservoir, when they do put the reservoir in, they use the ultrasound guidance. So for their neurosurgery fellows also, they have only that chance to just see it in the OR. And moving from there to right to doing the procedure itself, it takes so many times and so long time. And because this procedure is so rare, their chances of doing it themselves is very little. So they ask us if we can create some simulators for them so they can use it by their fellows before going to the OR in something called just-in-time training. So we created this phantom for them where you can see the needle. So they are using it now for their fellows. They practiced inserting the reservoir before going to the OR. And also the question I pose is, who will tap this reservoir? So once we get the reservoirs in, we used in the olden days that the neurosurgeons and physicians would have been tapping the reservoir, and because we are busy, we didn't tap them regularly. And some of those cases had CSF leak and infection, because if you put a foreign body there with a very fresh wound without tapping it aggressively, the pressure will build up and the CSF will leak. And this baby had the worst infection I have seen, with some ventricles full of pus. So we handed it to nurses because of the paper that Linda DeVries published, where they showed that if the nurses does the tapping, the risk of infection decreased significantly, and the chances of doing the tap on time was much higher than physicians themselves. And in fact, they were doing it sometimes too early because they were too diligent. But we wanted to take it one step further, because if you do the tap, you will need an ultrasound before the tap and ultrasound after the tap. And asking physicians to do that with all their busyness, it would be unrealistic. So we created this reservoir tapping simulator. We asked our neurosurgeon colleagues to give us one expired Ommaya reservoir. We sticked it inside a phantom, and then it goes inside a formula bottle. So this picture that I'm showing you, you can flip it upside down and you will see the bottom, the cap of the formula bottle. And then you can fill it with whatever the liquids you want. Sometimes we make it clear so it looks like a clear CSF. Sometimes I put a little bit of coffee so it looks like old blood. And sometimes we'll put some apple juice so it looks like it's clearing. Because over time, if you have done the tapping yourself, you will see that the CSF goes in stages, starting with something looks like car oil, and then it become like coffee, and then apple juice, until it clears out. So we trained our nurses to do cranial ultrasound just for the purpose of tapping. So they do the cut at the foramen of Monroe. These are some images done by our nurses. And the fascinating thing about the tapping, before the tapping, you almost always see the absence in the diastolic flow. And that's why in untreated hydrocephalus, you could see one of the worst cystic BVL that you will see in your career, because of that consistent and ongoing ischemia that's happening due to the pressure. And the main artery that get affected is the anterior cerebral artery, not the middle cerebral artery, because that is facing the main pressure. And what happens, we found post-tapping, the measurements, these are two cases before and after tapping. The measurement did not change much, but the Doppler, you can see the immediate restoration of blood flow after the tapping. The parents, they can see this. and also they can advocate for their kids. If in a case neurosurgeon said you guys are too aggressive, you need to slow down, but when the parents see before there was ischemia and after there's restoration, they advocate strongly for their babies. Now we are studying this. What we are doing, we are sending the images done by nurses compared to the formal ultrasound. Every week, these babies, they get formal ultrasound by the radiologist. We are sending it to our neuroradiologist to score them blindly and see if the nursing images and measurement at this foramen of Monroe level is as good as the radiology cuts. And if it is, then it can be generalizable. Other centers also can do that. This is the paper by Linda Debris I was talking about, and now we are well above 500 tabs with zero infection. And in fact, one of the cases that has CSF leak from the OR, and despite that, there was no infection. The neurosurgeons were in disbelief. They said there's no way this baby didn't have infection. But the nurses are so good, so diligent, and they do it on time. They do it 1 mils per minute. They don't go faster than that. They put their phones, and they are just way more diligent than physicians. Now, we'll move to the monitoring. Talk a little bit about the point of care ultrasound. Is there room for innovation in the monitoring? As you know, as neonatology, we like amplitude integrated EEG, and pediatric neurology, they like full EEG. And there's always this fight about they don't believe in amplitude integrated EEG, and we get intimidated by the continuous video EEG. How can we combine them together and make them speak to each other? Can we do that? And what we did buy a machine that can show you both, where at the bedside it shows the amplitude integrated EEG that we are familiar with. We can read it. In the background, with one click, you can visualize the full EEG. It goes to the server, so the pediatric epileptologist can read the same machine reading the full EEG, and our NICU team can read from the same machine amplitude integrated EEG. And who to train? And that was another question. Again, your best bet are nurses, because they are at the bedside, they know the patient, they have the best neurodevelopmental approach when they are dealing with babies. So we trained our nurses how to put a full EEG on instead of amplitude integrated EEG. Remember, we went from no CFM at all to a full EEG. And that was an advice by my mentor. When I went to, my mentor was a senior epileptologist. I asked him which machine should I buy, Olympics or Brains, where they were two different companies at the time. He told me, if you have the money and you don't have a car, don't go for a cheap car, go for a Ferrari. So why don't you buy the full EEG machine? That was the best decision we made, because it forced the both parties to come together and create our program. But anyway, we trained our nurses, and we published this paper where they were able to set up the EEG, the full EEG studies. And we created this framework that we are since being applying for all restricted procedures and skills. So restricted skills means the tapping, the point of care ultrasound, the EEG setup, and we always create modules where they can go through them and finish them. And then we have simulation, and then they have supervised practice, and then they need to do independent. We usually have a figure of three independent studies. They become competent. We sign them off. That goes similar for the neuro examination as well. And that worked well. This is a video of nurses putting the EEG, the full EEG on in a baby with HIE. And you can see how delicate they are, and how they are tuned for baby's care. Very gentle. We used to have these caps, and now they are out of the market. The nurses learned how to put full EEG without using the color-coded cap now. And then once they finish setting up the EEG, they will wrap baby's head and they leave the baby alone. It takes them much shorter, and their signal is really excellent. The other thing I have learned, and it was a great advice by one of my mentors, was if you don't publish it, it didn't happen. Always plan to publish all the intervention that you're doing. And by doing that, we were able to decrease the time to initiate EEG significantly. It used to be median of 39 hours, and we decreased it to 7.5 hours. And now we have a setup of 1 hour. If the EEG technologist cannot make it in 1 hour to the NICU, we ask the nurses put the EEG on, because we know if you leave the seizure more than 1 hour, it becomes harder to control in case this baby has seizure. As it saying goes, the neurons that wires together, which is very true. And then we had this two wards. We have the NICU ward and we have the epilepsy ward, where they read the EEG and we read the amplitude integrated EEG. Can we combine them together? So we created parallel services where we have one with neonatal neurocritical care. We formally read the amplitude integrated EEG, and we trained our fellows. We created templates for them. We forced them to read it every 2 to 3 hours, because otherwise you just ignore it. And in the epilepsy team, they come in the morning and they read the full study overnight. They don't necessarily read it live at night. Sometimes they do, but during the day they do. Then we combine both experiences, how many seizures we have missed, how many seizures we overcalled, and over time we get better and better in even reading the full EEG and being able to identify seizures. And again, you publish it. We did publish with Calgary was the first to publish that this model of introduction of continuous video EEG, we were able to decrease the anti-seizure medication use and decrease the number of baby got discharged on anti-seizure medication. You would think if you have more monitoring, you would pick up more seizures and your anti-seizure medication would increase, but it was the other way around. And the reason for that was the team was comfortable to wait to see the EEG before jumping the gun and treating any twitches in babies. Before, if it was getting too late, they were worried if they don't treat that seizure, the baby's brain would be damaged. And the other thing is, if you treat with phenobarb and then you put the EEG on, you don't know if there's no seizure, if this was because your treatment was effective or because there was no seizure to start with. And that because of that, these babies tend to stay on anti-seizure medication after discharge, and they will get outgrow their dose for about 3 to 6 months. But this allowed us to wean them quicker and discharge them anti-seizure medication free. Now, what's coming in the pipeline is the trends. And I think once we got more familiar, I call trends the AEG 2.0 or AEG on steroids. And these are different trend modality that help you to become more accurate, especially in the seizure diagnosis, give you the frequency and the power to be able to identify seizures more accurately. And as you know, there are more AI algorithm coming, and it's becoming better and better. Right now, with the neonatal one, the sensitivity is high, but the specificity is low. So it's picking up still some of the artifacts. And then we move to the HIE identification. So one of the variabilities that we had in HIE identification was in the neuro exam. And as you know, the components of the SARNAT neuro examination, there is variability in interpreting it. And that led to missing cooling in babies. Later on, you discovered they were moderate by having them seizure or their deterioration in their neurological examination. So we went back and looked at where are the areas of variability when it comes to the eligibility, and is there an innovation or innovative way to improve our ability to identify moderate to severe HIE. So we put this provincial program together where different kind of approaches to improve the accuracy. And what we find in the eligibility, these are the areas of variability. One, we wanted to reduce the human factor error. And that means in a way that you cannot go through the 50 pages protocol to review the eligibility. And if you look at the 2 tiers eligibility, they tell you if the court pH is below 7, then you look at the SARNAT, if the court pH is between 7.01 or whatnot, then you need to look at the sentinel event. So it's a little bit complex, and time is essence for you. At that point, baby is dying. You want to focus on the management, and you can't go back and open those protocols. So we ran the scenarios in the background to create an application where you only need to answer the question, and then the application will tell you whether this baby is eligible for cooling or not. But the problem with the application is garbage in, garbage out. If you put the wrong information in the application, it will wrongly tell you if this baby is eligible for cooling or not. So we wanted to improve the accuracy of targeted neurological examination. We put together a video where they can watch the component of SARNAT examination, the normal one and the abnormal one, to improve their ability to perform the examination. And we want them to practice the examination. If I would plan to train my trainees on a baby with HIE who's very sick, forget it, because one, they are too unstable to do that, and second, it's time bound. I can't call somebody in the middle of the night and say, hey, I have nice HIE examination, come let me teach you how to do neuro exam on this baby. And also third, you cannot teach group of babies on this very fragile group of trainees on this very fragile babies. So we wanted an innovative way to do the targeted neurological examination. We took the videos that we created in the targeted neuro exam, and we created a VR model where you can do the targeted neuro examination in VR. And for those of us who use virtual reality, you know there's no feeling component. There's interaction, but you can't feel unless you have haptic gloves. So we wanted to create a doll where you can feel the neuro examination, especially the tone assessment. And this was the first version. I bought a skeleton from Amazon, and I was trying to create it in my garage. This is the app. It's available for free, and it's basically run the eligibility criteria in the background and to capture. So far, it captured all the babies that are eligible. We have been using it for years now. And this is just in time also teaching. This is a cool or not too cool game that we created. If our physician or trainees or nurses want to go through it to remind themselves some types of scenarios, it branches you one way or another, and based on your answers, it tell you whether it was correct or wrong. And this is our targeted neuro exam video that we put together. And this is my student performing the neuro exam in VR. And then you will see me also performing the neuro examination. He's doing the pupillary reaction in VR. So there are a normal pupillary reaction and abnormal pupillary reaction to light. Yeah. Just forwarded. And then you see me here performing the heel to ear trying in a normal baby, and also the ventral suspension. And this is Norma, our neuro nursing lead, performing the tone assessment in the neuro doll that we created. And then we took all that, we implemented it into our outreach program. This was the first trip we did in 2016, where we visited the centers and we talked about the neuroprotection in HIE and improving identification. And eventually this evolved to create a virtual NICU program led by one of my colleagues, Ayman Abu Mahram. Again, if you don't publish, it didn't happen. So we showed that by implementing the outreach program using all those interventions, we were able to decrease the number of babies that missed schooling while eligible from 19.5% to 4.5%. And not only that, comparing ourselves to other centers in the country, we were center E there. We were the sooner to be called and the sooner to initiate cooling compared to other centers. And then ultimately, we looked at the impact of neonatal neurocritical care on the short-term outcome in HIE infants. And we found that the implementation of neonatal neurocritical care independently improved the outcome and decreased the incidence of death or brain injury on MRI. And this graph is from interrupted time series analysis, is type of analysis you do to make sure that your intervention change was due to your intervention, not due to the change in practice over time. And more, we compared ourselves to the rest of the country in terms of the death, brain injury, and composite of death or brain injury, and we were one of the lowest in the country in those outcomes. And we started working also on the standardization of classification of brain injury in HIE, and this paper is under review for publication, where we gathered neuroradiologists and neonatologists and went over the areas of variability when it comes to classification of brain injury in HIE, and we came into consensus. Then we wanted to test this innovation. One of our fellows, Rani Bashir, who is a neonatologist now, she tested the doll on her nurses. So we had two groups. One group had traditional teaching of the neuro examination. The other group had simulation. And then once they'd done that teaching, both of them went through the online module first. They did an independent neuro exam. They sent us those videos without telling us which group this was. And surprise, surprise, the group of simulation group was as good as the traditional group in performing an accurate neuro examination. And more surprising was that later on, the retention of skill was higher in the simulation group. And our interpretation for that was because during simulation, it's not stressful environment, so you are able to retain that information more. And if you think of yourself while you are intubating, I never keep the image of the vocal cord in my head because it's so stressful. You just want to put that tube in. Under stress, you have this post-skill amnesia. And probably that's why during simulation, they can retain for longer. And then it occurred to me that the 4 component of the targeted neurological examination, it doesn't require examination. And for the life of me, I don't understand why when I ask my fellows or physicians when they report about the neuro exam, they always start with tone. And tone is the least reliable component of the targeted neurological examination. We should leave it until the end. I think because we are afraid or scared of the tone, we always report it at the beginning. But anyway, so you have the level of consciousness, you have the spontaneous movement, you have the posture, and you have the seizure. All those are just by looking. Can we have an AI to look at this and be able to tell us that this baby is encephalopathic or not? So my fellow, who's now my colleague, Sujit, is working on that. And what we did, we are collaborating with a group from Brazil who had extensive experience in augmented reality and innovation techniques. And what we are doing, we are trying to create an algorithm, AI algorithm, so it will be able to identify babies, similar to the general movement assessment the app. So here's the first baby who is lethargic, is trying to identify the movement. And this is the graph that it got very simple. And then this baby who's crying and normal, his or her graph was more complex. And I think you guys have had a discussion about the complexity, and there's this new term called entropy and signal entropy. There's a paper from Stanford showing that signal entropy, if it's high, it has less, the babies have less risk of IVH. And that goes for most of the systems in humans. The more complex the signal is, the more healthy the human body is. When the simpler it is, the higher risk of abnormality. And more fun. So this was a baby that I had, HIE baby, severe HIE, very puffy. I could not open that baby's eye. And I knew from previous experience that the eye is the window to the brain. I had a case where it was a home birth and the dad did the resuscitation of his daughter until the AMS arrived. The girl came to us and she was pale like a paper. Terrible neuro examination. The only normal examination was her pupils were equal and reactive. And here she recovered, she was cool, her MRI was completely normal. And that sank in my head. I always believe in pupils, but they are so difficult to examine. Most of our pupil examination is not reliable because of that quickness. You need to do it quick, the eyelid's not opening. So we had this baby. And I thought, why don't I do ultrasound? Because the eye is closed. I have hockey stick ultrasound. Let me try. I just put a little bit of gel there, and I was able to see the pupils really easily. I asked the fellow to shine the light from the side, and I could see the reaction to light. It became smaller, and it was dilated when we stopped the light. And then now what we are doing is we know that there is the NPI with the papillometer. In adults, ICUs, they use it to predict the outcome, where it quantifies the size of the pupils, and then it flashes the light, so it quantifies the reaction. Then it's compared both eyes to each other. And now we are trying to compare this to our personal or human examination and see if this is better predictive for the short and long-term outcome. This will be first the pilot study just to prove feasibility, and based on that, we can calculate the sample size and go to higher study. Now, finally, I want to put everything together in two scenarios, how you use the multimodality in an innovative way. This is a case where an HIE case, the top row is your NIRS, and the middle one is the oxygen saturation. The third one is your blood pressure. This is the Doppler, and this is the EG. So in this case, you had solid high NIRS in the hundreds, and the oxygen saturation was normal, the blood pressure was normal. And in fact, here later on, when there was fluctuation in blood pressure, it mirrored into the NIRS. So that means the coherence was high or brain autoregulation was compromised. When you look at the middle cerebral artery Doppler, the peak diastolic velocity was high, meaning the resistive index was low. And once the resistive index is low, we know that the baby is going to reperfusion injury. And the EEG was flat. So if you think about it, very high NIRS, flat EEG, reperfusion injury, what you expect the MRI will be very bad, because there's too much blood going to the brain cells, neurons, but the neurons were too sick to utilize it. That's why it was most of it was going to the NIRS, and the NIRS was very high. And sure enough, this was the MRI for this baby, where this is an ADC map where black is abnormal, the whole brain was black. This was a total asphyxia. Compared to this case, where the NIRS started high in the 90s, but slowly dropped to the normal range. And the blood pressure, the oxygen saturation was fluctuating every now and then, but it was within the normal. The blood pressure started low, very low, but it recovered. And with the recovery of the blood pressure, the NIRS dropped, and meanings that once the brain had enough perfusion, it was able to utilize that blood and consume the oxygen. And if you put the picture, the EEG, in this case, there's lots of squiggles, and this means lots of activity in the brain. This brain was normal from the EEG point of view. And finally, the Doppler, you see the end-diastolic velocity is lower, so the resistive index in this case was higher. So it wasn't too much reperfusion, and the MRI in this case was normal. We put all this into our modules. We have many online modules with 54 CME accreditation. We made them free, and so far we have close to 1,500 subscribers to almost 8,000 modules from 78 countries. We also brought the cranial ultrasound London course to Calgary. It will be sometime in June if you guys want to join, and runs every year in London. It's a 3-day course, goes over head ultrasound, MRI, lots of hands-on during those 3 days. And I always think in the middle of thinking of all our interventions and research and data, we shouldn't lose sight of taking care of this human that we are handling. And that is because whoever saves one life saved the whole humanity. And this is the fun I have with my kids. They are much older now. This is my daughter trying our head ultrasound simulator. This is a brain dissection session we do in our kitchen when they were very young. And this is my son Ramin. He's not pleased by the EEG setup course that we had, but nevertheless, he was happier after we gave him some junk food after this. My daughter also, the nurses are getting trained on her head to set up an EEG. Now we have simulators, so we don't need them anymore. And this is when we were doing the POCUS TNE course, and you can see how happy he is. And they were practicing on me as well, just for fun. And I just wanted to mention one person that really I'm proud of Kauthar. Kauthar, she was my software engineer. She started with me as a student, and now she was able to she created most of our simulators, the EEG simulator, the cranial ultrasound simulator, and eventually she was able to create her own company. And I think sponsoring a person and mentoring a person and watch their success from the scratch until they are out there and independent. Something make you satisfied and proud. Thank you very much. I'll be happy to take questions.
Excellent, excellent. I think that was really fascinating. Lots of new insights and a lot of innovation I can see. There are a few questions. So the AI, the augmented reality was really cool because I think that's a limitation we are seeing. A lot of time the examination and the correct staging is not there, and often the babies are getting missed to be cooled, and that's something you're really focusing on. I'll take few questions quickly. How to stabilize electrodes in EEG with more number of electrodes are there. Again, more discussion in the workshop. We will be showing that. But any comment on if there are, so if you're doing multi-channel, if you have a montage of 12 or something, then how to stabilize them or
Yeah, it's the EEG is no different than ultrasound where the two enemies is hair and air. And in ultrasound, you treat that with putting more gel. In EEG, you need to with the tip of the Q-tips, you spruce the hair to expose the skin, and then you do your skin preps. After that, you can put your cup EEG uh, electrodes there, and they are very stable. Every now and then you need to go back and replace them, but so far it's effective, and it doesn't matter if you put 4 or 12 leads, they are far from each other.
yeah, lots of positive comments, inspiring, great, excellent. I think everyone is just fascinated with the things which are happening. So neuro optics. So I think ultrasound guided we had tried, but that neuro optic pupillometer is probably not available in India. That's something, often if the babies are swollen, birth trauma, or
Yeah.
you can't open their eyes. So I think the ultrasound works. But yeah, that's something if we have it, definitely
I don't
might
know how
be.
it will work, Dr. Kiran. I haven't tried it yet. I tried it on my own kids, and it's really nice. It works, but that's why it's a feasibility study. And I think if we prove the feasibility, we can probably convince the company to create a smaller version for pediatric. It's been used in adult. I looked up the publications. It's been used, but not in small babies yet.
Yeah, somebody's commenting doing ultrasound on the eyeball, will it not harm? So again, any
It's
comment on that?
Yeah, not really, because it's similar to cranial ultrasound, and there's lots of ultrasound of the retina. It's been done in ophthalmology. They do it as a standard of care. And as long as you're not pressing, it's the same rule for the cranial ultrasound. We should never press because you can cause bradycardia if you press on the anterior frontal. You're always gliding and making your probe swim inside the gel. And same, you put lots of gel on the eye and you can easily, it's not difficult, you can with the hockey stick probe. And the things that generate heat is usually Doppler, and you don't use Doppler in the eye ultrasound.
Can cool baby, what can cool baby with PS 6.8, obstructed labor, bicarb 3, no neurologically sign. So basically somebody's saying sharing very severe HIE with a pH of 6.8, obstructed labor should be
Yeah,
cool.
so you're basically saying with the clear criteria A, but no criteria A. Baby is not encephalopathic. So in that case, we do serial neurological examination and we document the serial neurological examination. We do it at 1 hour, and that's why we say 1 hour, because there is no evidence that if you go earlier than 1 hour with cooling, you improve the outcome. 3 hours where you draw the line before 3 hours, but not before 1 hour. And there's very strong evidence that good resuscitation is the best neuroprotective intervention. So if you focus in the first hour on the resuscitation and transition, you have that good 1 hour before doing your first examination. So you do your first examination at 1 hour, 2 to 3 hours, 5 to 6 hours. At any point, the baby is becoming encephalopathic, then become eligible for cooling.
Sounds good. Perfect. I mean, so I think what you highlighted, that was the focus we wanted to cover up, that I think focusing on the examination and then going and taking all the information, AEG, ultrasound, pupil examination, everything, and then, even MRI, and then putting it all together. And that's probably the best way to approach a child who's neurologically impaired. So looks like I think we've covered most of the questions. So with that, I think yeah, we can go to the next session. Thank you, Dr. Khurshid, again. Valuable time and very eye opener and inspiring. We will connect again offline with lots
Yeah,
of ideas and learning.
absolutely,
Great.
absolutely. Thank you for having me. I appreciate it. Thanks, Sid. It was good to see
Thank
you.
you. Thank you.
Bye.
Sure, we'll connect. Thank you. Thank you, Siddharth. All right, so Dr. Karthik Nagesh has joined. My session is still remaining, Dr. Karthik. Would you okay? I cover up in at least trial 20 minutes or 25 minutes, and then we'll go to your session. Is that okay? Because I think everyone has run past 10, 15 minutes, so it's almost 30, 40 minutes we are behind. Right. So I'll just start with my session and then I will go to yours. That's okay? So, yeah. Okay, thank you. Right. Yeah, I think somebody's raising the hand. Okay, so next session I'll start sharing from my end. Okay, so I hope everyone can see my slides and can yeah, hear me, of course. Yeah. So one sec. Yeah. So I'll be talking on another important topic, which we have a separate station in the workstations during the hands-on workshop on 5th of December. Again, I urge those people who are interested in learning more about this and practical aspects about this, please do register for the workshop on 5th. We have only few seats left, around 28, 30 people, another 5, 7 or 8 people probably will take, not more than 40 for sure. We have limited space. So, all right. Slides are not moving. This is just my little bit of journey internationally. I was fortunate to, get exposed to different hospitals in Australia, then Sick Kids, Canada, and then New Zealand, Qatar. And, then I returned back to India about 2.5 years ago and was heading one of the largest unit in Mumbai, Bijewadi and Vrajivadi, 130 bed NICU. And now currently I moved to my workplace, which is MRR Children's Hospital, a very advanced kind of a setup, which is again built in collaboration with Sick Kids Toronto. And I have nothing to disclose except for two things that, Osapaka, the company who made the Icon monitor has, will be giving us devices for the workshop. And also the intention of this workshop and making it so comprehensive that, whatever I have been exposed to, I would like to, more people to get exposed to, at least, there is something happening on the other side of the world. And in India, we are not behind. The technology is moving very much advanced. We are not always resource limited everywhere now. I think we should, come out of that mentality that, okay, we cannot have this. I think the aspiration is to have everything and anything possible in the world. And that was the whole idea of, making it more advanced. And those who are interested in neonatology, there's a big Pandora which can be opened if you use technology for your NICU care. This is quickly just a background. Again, I like this analogy and I've shared it some of my previous talks in shock. We spoke a lot yesterday on why we talk about cardiac outputs, stroke volumes. Dr. Kumara and Dr. Bhavya spoke about it, and why reliability of blood pressures and the other clinical parameters might be limited. So if you imagine a Mr. Patrick's 3-story house with, sort of 3 levels of bedrooms, guest bedroom at the bottom, master bedroom, and children's bedroom at the top. And there's a water reservoir and a pump which is supplying the water. Now, if we compare this house with your body, with the brain at the top and the middle vital, heart and lungs, and the kidneys, etc., at the bottom. And this is your this analogy is comparing with our hemodynamic system, which is connected with the preload, heart, and the afterload. So basically what happens if there is a leak of the water, then obviously the flow will drop. So that is analogy is equivalent to your hypovolemic shock. So in cases of placental abruption, cord event, severe diarrhea, sepsis, the water tank level is less. So preload is less and your blood pressure might be normal. But what we need to know, you cannot completely rely on blood pressure at that time. What you need to know is what is the water level. So what's the flow happening in each and every organ of the body. And that's why, again, importance of knowing the cardiac output and the flows. Secondly, if there is a abnormal redistribution, suppose there are guests in the bottom bedrooms, there will be more water utilized in the bottom and then less going to the master bedroom and the children's bedroom. So again, this analogy holds true for uh, distributive shock. So sepsis, NAC or SIRS, what happens there is a redistribution, and the vital organs like brain may not get enough of the cardiac output. And again, your blood pressure in the initial stage might be normal because of the compensated shock, and it will drop only in the late stages. So your vital monitors may not tell you a lot of things, and again, you might have a monitor which needs to tell you about the what exactly the cardiac output or exactly what is the saturation level in the brain. So that's where Dr. Valerie spoke about the use of the NIS monitor. So those also can be. Sorry, one second. I'm just trying to open up the. Where is the pointer? Yeah. So yeah, so use of NIS monitor, which will tell you about the what is happening in the brain, and the icon monitor or the cardiac output monitor telling you exactly what is the blood flow. Similarly, cardiogenic shock. So if the pump is failed, there is no water going or less water going to the house. Similarly, you see that in the cardiogenic shock, cardiomyopathies, hypoxic ischemic, HIEs or metabolic or any heart blocks will affect the pump. Again, your echo can tell you about that. But if a function is deteriorating, you don't have an information about it continuously. So again, you need a monitor which will tell you what's happening with the heart function, what's happening with the outputs and everything. And again, last but not the least, obstructive shock can be there sometime. So pump is working, water is going, but there is a block in the pipe system. So less blood, less water going to the house, less blood going. So obstructive shock like cardiac tamponade, pneumothorax, coarctation, where again there is a hypotension and we need to know. So basically, what we are trying to emphasize is not only the focus of us is monitoring and assessing a hemodynamic status. You need to know what is the preload, how much is the intravascular volume, what is the contractility of the heart, which also includes the heart rate. You have enough heart rate and enough contractility, and afterload, which is determined by your vasoactivity, which maintains your blood pressure. And we need to have all the information to know the correct hemodynamic status. And that's why an echo has its limitation. It's useful tool but needs training, and a lot of observer bias is there, not continuously available. You can't keep doing echoes because the baby might be dynamically changing, and that's why a lot of time you need something beyond echocardiography and more monitors like this. And today we spoke about trend monitorings. Dr. Sony spoke about hero monitoring. I think we did cover few of the echo aspects, but that's a separate workshop, so we're not focusing more on that. Dr. Valerie spoke about needs, and I'll be talking about electrical cardiometry or the non-invasive cardiac output monitor. And all this information can be integrated together in something called as integrated evaluation of neonatal hemodynamics. And it not only adds up your clinical, multipara, ultrasound, NIV, Neocon, and needs information. And I can tell you at the end how the consultation can be given based on all this information from all the parameters. So NICOM or the cardiac output conceptually. So in 2004 in adults, this was a concept that, measurement of the cardiac output was always difficult. So there was always need that some indirect ways of determining the cardiac output would be useful. So the scientists were looking at it, and Nicole Coden came up with this, that estimated continuous cardiac output. Somebody asked a question yesterday, what is ESC/SCCO? So basically, they found that basically if you they found a correlation between the pulse wave transit time and the stroke volume. So if you plot the ECG and the peripheral pulse wave, there's a correlation how this pulse wave transit time will change, and there is an estimation of a stroke volume and thus the cardiac output by taking ECG and these two parameters integrated. So you may not get an exact value, but you might get a trend, and that was the early concept about estimating the cardiac output and trends of monitoring the cardiac output. Now more research has gone in, and there are more and more monitors which are available for monitoring, including those for newborn in the market. They are more used in adults and pediatric population, but they are using in newborns as well, and we had used this in my previous unit. So as you can see, these are the three types of monitor, and we will be having this monitor at the workshop on the 5th of December for displaying and explaining in detail. But I'll go through the theory part of it today. And this is the icon monitor, and based on the electrical cardiometry principle. Now, the principle of um, electrical cardiometry, or I'm just missing the one slide, I think, which is hidden. But anyway, basically it uses either bioimpedance or biointerference. The concept is the electrical signal is passed through the body, and how much is the impedance or the resistance offered by the blood flow, that will calculate the various parameters. So what this machines does, what different these devices does, for example, this icon particularly does, that you put two sensors, one on the forehead, one on the neck or on the shoulder, and then those are the inner sensor, they're the outer sensors, and they send a signal across the chest. And then there are receiving signals or measuring sensors. One is on the chest and one on the thigh, left thigh. So this electrical current is passed in this direction of the heart, and what is the resistance offered to this electric current will calculate based on this algorithm, which takes ECG into account and various voltage changes. Just for example, how this resistance changes in systole and diastole. Imagine San Francisco, where Dr. Valerie is from. She's got a traffic which is very streamlined. So suppose a current or a biker can pass through the traffic lines very fast. So the transit time is very less. So they can go pass very swiftly. So in systole, the RBCs are aligned very swiftly. So the electric current can pass very swiftly. As against in diastole, this is our Mumbai traffic. So in Mumbai, the traffic is very chaotic. If the bikers have to go, they have to take really long route, and they take longer time. So in diastole, because of the malalignment of the RBCs, the electrical current will have a more resistance. And that's why this machine will pick up systole and diastole just based on these voltage changes and how much is the resistance offered in systole and diastole. And then how fast, how high levels, what's the amplitude, what's the duration. Based on that, I will not go into much detail about the various equations, but this mathematical algorithm will give you a lot of parameters which are of our interest for assessing the hemodynamics. And the sensors which are used are very much similar to your ECG electrodes, and they're different for adults and pediatric and different for newborns. And again, the sites generally they recommend to put it on left side, but what our experience is that the B electrodes, better you put it in the newborns on the right side and A on this side, and the receiving electrodes on the left side, on chest and the thigh, so that the electric current is passed in this direction. So interestingly, this device will give all the parameters which we're talking about since yesterday. So we need to know the flow. Again, we need to know what is a stroke volume, or what is the cardiac output or cardiac index, which is divided by the birth weight. So minute to minute and continuously, it will tell you the stroke volume, cardiac output. It will tell you, it will calculate the systemic vascular resistance. Again, that's something which we don't get displayed, and it is calculated based on the blood pressure and other parameters, which we'll talk about. It will tell you about how much is the contractility, and there are two parameters for that, something called as systolic time ratio and something called as icon, which is also the name of the device, icon monitor. But not to confuse, they have basically icon stands for index of cardiac contractility. So icon, then it will tell you about the fluid status, and there are two important parameters, TFC, thoracic fluid content, and stroke volume variation, and I'll be talking about it. It does give you DO2 as well, but not much useful. And in next few slides, I'll tell you about each and every parameter. So basically, it gives the algorithm will compute. We have to put up the weight of the baby, length of the baby, so it will calculate the body surface area, and the monitor will display all these parameters. You can select what parameters you like to use. So stroke volume, cardiac output, TFC, index of contractility, SVR, or stroke volume variation. All this will be displayed. Now don't focus on these numbers right now. This is a display slide. as many numbers are adult related, but what I wanted to highlight here is what this machine does. It basically plots the all these parameters in this form, and these dotted lines, as you see here, they are the normal range for that particular baby. So they have fed the normograms already in the device. So what will happen is it will automatically plot a normal for each and every parameter. And what you need to know is you don't have to worry about each exact number. You just need to see if the parameter is in the normal range. Like here, the stroke volume is normal, cardiac output is normal, TFC is normal, icon is high. So you can see it's out of range because the range is here to here. So this is out of range. So your contractility is high, maybe the child is on hyperdynamic, on inotrope or something like that. So suppose if the SVR is low, it will be somewhere here. So out of range. So just middle two lines, left side of it is below the range, and right side of it is above the range. So that's how it will calculate, and it will tell you about the vascular system, what is happening with the systemic vascular resistance. It will tell you about the contractility. It will tell you about the fluid status and etc. And it also gives you a trended data. Again, don't focus on individual. This is just a schematic representation, but this will give a trended data and drop in the cardiac output. Sometimes there could be false pickup, but the trend is again important to monitor for the heart rate and the cardiac output. Normally, we know that in newborn it is around 150 to 350 mLs per kilo per minute. And there are studies looking at the correlation, which I will be showing briefly. But basically, it may not be exactly correlate with your cardiac output measured on the echo, but trend will be important. It might be 20, 30 or 50 points out, but at least the trended value will be measured, and you get a response, response to your inotrope also, if the cardiac output improving, or if the child is deteriorating, the drop in the output, cardiac output, can be measured in a continuous way. The index of contractility, again, as I said, it is it based on this algorithm, it will tell you if the contractility is high or low. Again, there are various ranges, but again, not focusing on the number. It is a surrogate of your ejection fraction and fraction shortening. So if a fraction shortening is reduced, your icon will be reduced. And if your FS is normal or high, your icon will be more. Just remember that. There's something called as STR, systolic time ratio. Again, it is calculated by this formula, but what it means that suppose basically it's a ratio of your pre-ejection period to left ventricle ejection time. So if your heart function goes down, your pre-ejection time will increase, and that's why the ratio will decrease. The ratio will increase. So basically, it is relation to what is happening with your pre-ejection period and left ventricle ejection time. So overall, if the difference is more, so if the STR is high, then it depicts your poorer heart function. So just to recap, higher the pre-ejection period and decrease the lower ejection time. So overall, STR will increase. So increase in STR is bad, or marker of a poor heart function. Again, just a surrogate that if it's more than 0.5, it is corresponding to less than 50% of the ejection fraction. So suggesting the heart is failing or cardiac dysfunction is happening. So lower STR values will be abnormal. SVR is calculated by this formula. Again, don't focus on the number, but basically mean arterial pressure will be calculated by the blood pressure, which we will be entering in this machine. It will presume a CVP because it's not measured based on the age. Generally 5 to 6 is what we know. And then the cardiac output also is measured by this machine. So it will calculate the systemic vascular resistance. And again, it will drop if it is low. See here, this is the range. So this is high SVR. So if it's low or high, this machine will mark, and you will know that what is happening if the baby is vasodilated or vasoconstricted, is on inotrope, or is decompensating or compensating. All these things, information will be there. And there is something called as TFC. Just remember, basically it measures the intravascular fluid, and more the TFC, that means baby's edematous. It just tells you there is a tissue fluids, tissue edema, and less the TFC means less this thing. So all the babies who are edematous, even if there are like pleural effusions or pericardial effusions, falsely the TFC might be high. So any fluid content increase in the thorax or edematous baby, you will have a higher TFC. So that's all it is telling you. Now, other thing is stroke volume variation. Naturally, now stroke volume variation is a naturally occurring phenomenon. So some of you who have used invasive blood pressure monitoring might have seen this stroke volume variation. So what happens? Suppose you are fluid depleted, your arterial pulse peak, the minimum and maximum might vary. So normally you will see a very smooth wave, but in the stroke volume variation, there will be some waves will be peak will be higher, some will be lesser. So what happens is uh, more the variation for the stroke volume, less is the fluid status, or it suggests that baby is fluid depleted. So if you have a high stroke volume variation, that means your low intravascular fluid status or low preload. So higher the SVV, decrease is the intravascular fluid status, is what the interpretation you take from this. So coming to this is your hemodynamic assessment we spoke about. We need to know the preload, we need to know the contractility, we need to know the afterload. So in summary, this preload will be told by your stroke volume variation, which will be high, or your stroke volume, which will be low. Contractility will be told, will be informed to you by the icon, which is the index of contractility, or STR, stroke systolic time ratio, which will be high. And afterload will be informed to you by what is happening with the stroke volume and what is the SVR. So with this machine, you will have all the information what you need for assessing your hemodynamic status. So those who can put up in the chat box. So in hypovolemic shock, can somebody quickly type in chat box if you have understood what will be the main problem, what will be the low, in what will be the parameter which will be affected in the hypovolemic shock? Quickly write in chat box. I'll give like 10-15 seconds. What will be the primarily thing which will be affected? Is it the preload? Is it the contractility? Is it the afterload? And what will be the parameter which will be affected? Please type in the chat box. So stroke volume variability will be high. Yes, correct. Preload. So low preload, which will be depicted by high SVV and low stroke volume. So that's correct. So this is what it will be shown. Because primarily the fluid is less, you will have a high stroke volume variation. And because there is a less fluid, you will have a less stroke volume and less cardiac output. But there is no effect on contractility because heart function will be normal. So you don't need inotropes. You just need fluids here. What will happen in septic shock? What will be the primary thing? Suppose we say somebody is in a warm shock, early warm shock. What will be affected first? Please type in the chat box. What will be the first thing will be affected, and that will affect the blood pressure. So please chat 10 seconds, 15 seconds, I leave. Both pre and post. Yeah. So high cardiac output, correct. So cardiac output might be high to compensate. Icon may or may not get affected. So contractility may not be affected in the early stage. SVR will be low. That's correct. TFC might be have if you have a high third spacing. SVR. So most of you are right. Let's see what affects in the septic shock. So basically, as pointed, first thing will be drop in the SVR. So because the baby gets vasodilated, your SVR will drop, your diastolic blood pressure will start dropping. Then the body will start compensating by increasing the cardiac output. So you will have a high cardiac output. But in the early stages, your icon and STR will be normal. So you might have a normal contractility because heart is not affected. It's just the vasodilatory phase and third spacing phase. Somebody did mention about TFC. Yes, you're right. In early stage, it is not affected, but in later stage, you will have a high TFC. So very rightly said, once you start third spacing, TFC might be affected. So that I hope that's clear. So that's the septic shock. What will happen in the cardiogenic shock? What will be the first thing which will get affected? Please type in the chat box, few seconds. Icon, 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 icon. Perfect. And because of icon is affected, what will be affected? What will drop because the contractility is less? So because heart is, yeah, so afterload or the cardiac output. Perfect. Perfect. So afterload is something related to SVR. So don't get confused. So afterload is something the vessels are putting on the heart. And so if you have a cardiac output which is low, so let's see first what happens in cardiogenic shock. So yes, first thing will be the icon, which will be affected as shown by all of you. Also the STR will be high. So these are the first thing, because any cardiac dysfunction, it will affect. Because this is low, it will have a low stroke volume and low cardiac output. And SVP and this thing might be normal. Now, SVR should be normal in the cardiogenic shock. Body will not raise the SVR. If body raises SVR, the heart will fail. And that's the mistake often happens. Suppose you start dopamine or norepinephrine or vasopressin. In a cardiac dysfunction, the heart might fail because you are suddenly increasing the afterload on the heart, on the failing heart. So somebody is tired and you're asking to lift 100 kgs, the heart will fail. That's why this monitor will tell you if the cardiac function is poor, then you need to support with the the inotropes, not with the vasopressors. So again, that's how you interpret and take a conclusion. So this, I mean, so this machine actually gives you a lot of information. So if you know that there is a low intravascular volume in hypovolemic shock, as suggested by low stroke volume and high SVV, then the treatment is only fluid or blood transfusion and no inotrope required, and this baby should recover. Suppose your cardiac output is affected because of the cardiogenic shock, or heart function is depressed or something like that, which is suggested by your low icon, high STR and low cardiac output. What you need is inotropes like dopamine, epinephrine, maybe milrinone. Again, milrinone is good in such situation because it increases the contractility and decreases the afterload because it's a lysotrope. So it causes a reduction in the afterload and improving the contractility. And if your blood pressure is dropped, as in sepsis in early stages, because of the low SVR, and high cardiac output, then what you need is a vasopressor, because contractility is normal. No point in starting dobutamine or epinephrine or milrinone. What you need to start is norepinephrine probably, or dopamine or vasopressin. So if you understand the concept, and this machine will tell you about what's really going on with the baby, and then you can take the actions accordingly. A lot of questions we are asking about validation of all these devices which we are talking about. So yes, it is validated in the, you can see in the adult ICUs, pediatric ICU, and also newborn ICU. So it is validated against thermodilation methods, transesophageal echo, and fixed thermodilation principle as well in the research setting. And again, this was a study from a unit in sick kids. Danny and Patrick, so you can see that this is correlation of the cardiac output monitor, cardiac output measure on this device versus cardiac output measure on the echo. And as you can see, there's a linear correlation. So the number, the absolute number may not correlate, as I was mentioning. It might be 20, 30, 50 points out, but the correlation and the trend will be correlating. So again, it's good for monitoring the trend. So you do an echo and then you monitor with this monitor. TFC also has been studied in pediatric population, and when the TFC is increased, it suggests fluid overload, and we all know that whenever the child is third spaced or fluid overload, the chances of mortality is very high. So basically it just tells you the this thing. But again, lot of pediatric studies, less newborn study. We had, in fact, we are about to publish some data from Sidra, but again, there were a lot of issues we also faced initially, which have been overcome by the developer, and we are getting more trended data and more accurate data nowadays. And there are studies talking about accuracy and precision of the NIV, and obviously this machine cannot replace the echoes, because the absolute values may not be correct, but it can complement. And you're monitoring, and because it's giving you continuous monitoring, and the trends are again more important. So if you want to have a goal directed therapy, so before starting the inotropes, during the inotropes, after the inotropes, the trends which might be useful, and also to teach to the your fellows and resident, at least they would conceptually understand that what is a preload, what is the afterload. It's not about only blood pressure and heart rate and saturation. It's always about the flows, preload, afterload, understanding the SVR and all those things. But there are limitation. Again, availability is an issue. We have it actually currently right now in my unit, which we're using. And the cost is a concern. Ongoing cost signals and these things are there. Um, you need flow sensors, and yeah, you have to repeatedly use for one per person use, and the cost is there. Again, sometimes there were some inaccuracies and poor signals in a baby who are edematous, but recently again we trialed it in our current unit, and the newer devices, the newer sensors are pretty accurate, and almost for 3-4 days continuously without any interruptions we could monitor them. So I think the machine is also evolving, so maybe there is a good use case if we get a correct data. And yeah, but still limitation in the fluid status. Sometime PDM might affect, and more so what we saw that babies on HFOV, or those who are on EG or CFM monitoring where some electrical other signals are going on, then the values are not very accurate. Also, if you are on ECMO, or if there are arrhythmias, or if there are some procedures, surgical procedures are done which will interfere with the flow, then it will just, the algorithm will get disturbed and your accuracies will not, or the values will not be accurate. So there are limitations for this, and we are again running over time. If I can spend 2-3 minutes before Dr. Karthik Nagesh talked, but this is summarizing what Dr. Valerie spoke, or Dr. Khurshid spoke, and what I covered. How this different parameters will help you. So this is a baby 33-weeker and became hypotensive with low diastolic. See here, actually the stroke volume variation. This is what I was talking about. You can have a stroke volume variation even in the intra-arterial blood pressure monitoring with such a low diastolic. 15 is the diastolic, and so it's a severely sepsis, and this baby also had a pulmonary stenosis. So you can see the cardiac output was very high. This baby's cardiac output was almost around 350 or something, and what we saw in the EC monitor was because baby was on inotrope, icon was high, but SVR was low. And yeah, the SVV was slightly on the higher side, and baby's TFC also was more. So it was edematous baby. So this is how your monitor can tell you this is actually the baby's. This is the real baby whose photo is this. And so third spacing was happening, and you can see same baby had a very low NIRS value, and after intervention, you can see the norepinephrine was started, and the blood pressure trended improvement. There was a fluid bolus given, blood transfusion given. Within like 4 hours, the NIRS value started improving to 22, and then it reached up to 45 by next 12 hours. So, monitoring cerebral needs, icon, multipara, you can integrate all together, and it gives you a lot of information. This is the real case in our unit. And again, this is another one, 34-weeker, very poor contractility. As you can see, heart is hardly moving, septum is hardly moving. You can see the ejection fraction is only 28, and fraction shortening is almost 12%. Very significant dysfunction, cardiac dysfunction in this baby. And you can see the icon value is very low. And this is again a real case, and very low cardiac output also, which was I think cardiac output was 80 or 90 on the echo. And again, third spacing, baby was edematous. SIRS was there, and so we started with epinephrine followed by milrinone. This is again the cerebral NIRS value also were low, 35, and again we had an improvement over almost a week for this baby to come out of this state. And last but not the least, again this is covered by both Valerie and Khurshid, and again we see this all the time. Baby who was cooled. This is again a real case, and this baby had a hypotension, metabolic acidosis, high lactate. You can see the dobutamine was started here, and the blood pressure improved. But this baby's again the icon was low, contractility was low, and cardiac output was low. And this is the NIRS value. See the NIRS value very high. So 80, 90. When you see a high NIRS value, on a baby who's moderate to severe HI, that means there is a low consumption happening, cerebral consumption happening. So you have to, it prognosticate a poor perfusion, a poor outcome, because the baby's brain is affected. It's affecting the consumption, and that's why you have a high needs value. So again, you can see how all the parameters and all this monitor which we covered can apply to different scenarios and give you a lot of information. Again, dopamine with the improvement, all these parameters. And this is just the last slide. And this is the integrated hemodynamic monitoring reporting we look like. So you look at the clinical status, you write the history, you look you write the systolic mean blood pressures, you look at the cardiac output and on the echo, and you have all these parameters on your non-invasive cardiac output monitor, and you have this parameter cerebral needs monitor on the needs monitor, and lactate from the blood gas, and you put it all together, and then you know exactly what's going on in the baby, and that will give you a lot of uh, insight about what needs to be done. And again, this is published by Yasir and his team, about in the cohort of 43 preterm. So it has been again validated. More information have, more closer to the reality you will be. So yes, clinical science have limitations. So again, focus on oxygen delivery, stroke volume, cardiac output, and use of needs. But obviously, you have to be mindful that these modalities are still evolving in newborns. If you have it, it's good to have. They're not must to have, but if you have it, definitely it adds a lot of information for clinical decision making. With that, I'll end, and happy to take questions for a couple of minutes. And again, Dr. Mohit and myself, we do run the echo course, and we do cover a lot of echo and head ultrasound, and again cardiac output monitors, and all the details about this parameters in our course. The next one is starting in January. With that, I'll end. Thank you. Sorry for going again a little bit over. Any questions? What all parameters we have to enter manually? Okay. So if I can just quickly, manually, I think you have to enter initially the baby's weight, body surface area, and the blood pressure. The blood pressure nurse has to measure, and the newer devices has got a BP cuff, and automatically you can set every 15 minutes it can measure. Rest all will be measured automatically. Can we detect hypotension? Yes. Again, the blood pressure will be entered, so you will see that SVR is going up. Which one is better non-invasive cardiac output monitor? So currently in India, only one, that icon, which we'll be demonstrating you in the workshop, the one I explained on, that is the one which is available. The others are not still readily available. Okay, so with that I will stop. Those who are coming for the workshop will go much more into detail about the practical aspects and demonstrate it. Okay. Too much edema can affect. Yes, I did mention that too much edema can affect the sensors. So it has limitation. The cost is around 10 to 15 lakhs, that range, including a digital monitor which actually display all the parameters in a continuous way. All right. Okay. So with that, I'll stop, and we'll go to the last presentation for today. Again, very interesting presentation. I'll let Dr. Shamla introduce. I'll just open up slide for Dr. Karthik Nagesh sir. Sorry, I'm just Dr. Shamla, you there?
She's not there.
Okay, she's not there. Okay, okay, one second. All right, I think one sec. Just trying to open up. Just having some glitch. Just one sec. Sorry, sir. Just Yeah. So our next speaker, Siddharth, you want to introduce Karthik sir, or I am happy to. I think your voice is not. I think maybe I can start off. So most of us in India, Dr. Karthik Nagesh needs no introduction for those who are practicing in India, even overseas. He's got a, as you can see, he's got a very long CV. He's chairman and head of the Department of Neonatology at Manipal Children's Hospital, Group of Hospital, and adjunct professor of pediatrics in Manipal University. And he's also advisor for telehealth NICU program for Karnataka State of Health Department, and that's what his today's talk is all about. And he's been pioneer for lots of things. We've been hearing his talks for last many years. First tertiary center NICUs in India, and I think early person who has experienced even in surfactant therapies in who pioneered in India. And as you can see, he's a academician, teacher, and he's won lots of awards and lots of publication. Very academic, 101 publication, 22 book chapters, and more than 400 invited talks. So stay tuned for very interesting talk. He'll be talking about telemonitoring in NICU and probably also in transport. So over to you, Dr. Karthik sir. I'll just make you host.
Thank you so much, Dr. Kiran. It's indeed a wonderful pleasure and privilege to be here. Thank you, Dr. Shamla, as well, and the Neocon for inviting me. Am I audible, Dr. Kiran?
Yes, very much. And you can share your slides.
Can I be allowed? Yeah, now I'll share my slides without much ado. Just 1 second.
Perfect, sir.
Can you see my slides, please? Yeah.
Yes, sir. We can see, and yeah, we full screen also.
Yeah. So I'm really fortunate to be talking today about the next paradigm, possibly in the care of neonates who are sick in the periphery, and also currently even in hospitals like ours, where the amount of qualified neonatologists is not enough to look after sicker babies, but then telemonitoring probably has helped us look after them better. And in a way, I think this is probably going to be the future. And this last about 2.5 to 3 years, I've had some experience on monitoring babies remotely through tele-NICU services, both in the private sector and in the government sector. And I'm going to share some of these thoughts with you. And also, I have the opportunity today to also share some of the data from my colleague, estimated colleague, Dr. Sanjay Wazir from Gurgaon. He is the director at Motherhood Hospitals. He is also running a robust tele-NICU program in northern India. So we'll be sharing some of our data. I hope Dr. Sanjay Wazir has joined. I had asked him to join as well. Now, what happens is, we are all very aware that progress in neonatology has happened significantly in respiratory care, technology, and you heard such fantastic talks today, and I really admire all the speakers today for all the insights they have shown into neonatal critical monitoring and the technology. We cannot be separated away from technology, as we all understand as neonatologists. But then it is not the technology and just putting off a ventilator or some cardiac monitoring devices which is so important for us. It's basically we, the people, who have to be intensively caring for babies. And I'm very convinced about it that whatever technologies you have, if you're not looking at the technology and not interpreting it, like the data which, for example, Dr. Soni was talking about, the mind sometimes cannot interpret this data all the time. And we are not very free all the time to look at the data which is emanating out from the cardiac monitors, as Dr. Kiran Modi also explained right now. So therefore, artificial intelligence comes into play. But at the same time, just look at the situations where in the peripheral units, in the low resource situations especially, there is data coming out of the monitors, but people don't have the time to look at that. And you need somebody to help them look at the data, interpret it, and give them some solutions to look after their babies properly. And unfortunately, qualified trained neonatologists are not enough in this country. So if you look at the data, about 8 years ago, we had the chance to publish this data. In India, we had at that time close to 2,000 neonatal units. Now, of course, it must be much, much more. Maybe we have close to about 4,000 to 5,000 neonatal units delivering quality care. But that's not enough in this country. It's very heartbreaking to know that in a baby in India, we have more than 3.5 million babies which are born preterm every year, and most of the times the cause of death is still prematurity, apart from neonatal infections and birth asphyxia. So considering this picture, because I realize a lot of audience here is from the Western countries as well and from Middle East as well, I just wanted to tell you, just to show you what is the reality of the situation in this country, where we have more than 25 million births every year, and 1/4 of the deaths in the world are happening in India. And this is the reason why we have to do something to see what best we can, how to salvage the situation. If you look at the recent data, much as we have level 3 units proliferating, much as we have even level 1 and level 2 units giving basic care for the newborns, and NICUs like this are proliferating, like the NICU of ours, which I have shown the picture here, there are only about 150 qualified neonatal doctors, super specialists who are trained, and some fellows are trained about 300 of them every year. But that's not enough. You need typically one NICU for about, with 30 bed kind of NICU for about 1 million population, and that's not enough. And the cost of NICU care is also going up. This is extrapolated data from old data. The only data which is available, which you could find in the literature, was in 2003 from PGI Chandigarh. But if I extrapolate the data based on present day cost, the cost of treating an ELBW, even in the private sector or public sector, is about 13 to 15 lakhs. And that is quite a big expense for the family, or even if it is insurance, quite a big expense. So we are therefore a situation where there's a critical need to improve neonatal care in India. So look at all the kind of preventable deaths we can have, the situations where a lot of morbidities are occurring in surviving newborns and the residual handicaps, and how we can probably even utilize the data which is already available and see what best we can use some kind of optimal resource utilization to see the data. I'm talking of even the government sector where babies are being treated in taluk hospitals and SNCUs, even in district hospitals. The biggest challenge is still limited access to trained, qualified neonatologists who can understand the criticality of the situation and do justice to these babies. But there have been infinite possibilities now happening. Because of the advent of internet, we have remote monitoring available now, we have digitization, we have mobile apps developing. But I think the firm way to go ahead would be the creation of telemedicine and e-NICUs. This is just a short, I've been quite a lot into remote monitoring for the last 7 to 8 years or so. This is just a small publication which we did on even our own babies who are getting out of our NICU and going into the peripheral wards or even going home, and babies who need care. And we found that efficacious continuous monitoring using simple digital apps which are mobile based were able to create data which could be sent to the cloud, and we could monitor these babies through telemonitoring availability. So this is some very small data which was available to us. But at the larger scale, we also found at the same time that fetal monitoring was possible, and now more and more obstetric consultants in a city like Bangalore are giving these fetal monitoring devices to their patients to be able to monitor even antenatally the fetal heart rate, fetal ECGs, and the fetal movements and the NST. So remote monitoring is going to happen, and it's going to lead to better outcomes, and this is what we have realized. Now, what is the concept of a smart remote NICU? I just wanted to explain this in this slide. Basically, it's a hub and spoke model. You have a hub where qualified trained neonatologists are available round the clock along with trained nurses who are able to identify problems. The remote unit is basically the remotely located neonatal unit where doctors may be very busy, the nurses are also busy, there are many patients to look after, but then there is a kind of 24/7 real-time data input from the remote unit to the hub. It's a hub and spoke model. And at the hub, we are able to get the data from these babies directly from their monitors or added information from the patients, from the doctors or the nurses, which is fed into the system, and we can see the data. And then based on the data and analyzing it ourselves, we can give them solutions for looking after their babies better. So the hub is where we, as some kind of pilot projects which we did last 2.5 years, we were sitting and trying to monitor these babies. and I'll share some of my experience which we had the chance. So right from the time when a baby would come to the triage area and the baby needed a NICU admission, right from deciding the admission criteria for the baby and deciding with the local consultant, who is the doctor who was available and was partnering with us. Mostly it was a pediatrician, not necessarily a neonatologist qualified in intensive newborn care. He would be really all the time keen to know what next to do and what would be the best outcomes required to be done for the baby, best treatments. So there was a lack of knowledge, that is a gap we had to fill. And the bridging of the gap was what we looked at. So admission criteria, procedures and communication. So suppose he had to do a, like for example, just putting in a intubation for a baby or resuscitating a baby, we would be monitoring him and telling him what next to do. Or if a baby had collapsed, for example, with a pneumothorax, we'll explain to him how to go about and trying to do what is best for the child. Investigation guidelines, data from the lab directly in some smart hospitals in the periphery, we were able to go into their HI system and get the labs directly into our system through electronic health records. We could see that trends were happening and we could even tell the doctor or the nurses on site. Likewise, x-rays, images and other modalities were shared. So overall, this was a kind of hand-holding the doctors in the periphery and trying to help them look after their babies better. So the essential pathway of making a tele-neonatology approach is ideally to get all the data from the patient monitor directly. You can see these devices which are all available. These are called IoT or Internet of Things devices are available. They can speak to ventilators of any make. Nowadays in India, most ventilators are able to speak to some of these devices that are available even in this country. Take the data input from there, go on to these IoT devices, and the data is then thrown into the cloud. And from there, it comes down to servers. And from there, sometimes we can build in an AI algorithm, which is of course futuristic. And then at the hub, we have doctors and we have trained nurses looking at these data and trying to determine alerts. And then we have 24/7 audiovisual communication with the treating doctors and the peripheral doctors in the spoke. Likewise, data input through hospital information system to the electronic record could be done even by a tablet device at the bedside or a computer at the bedside of the peripheral unit, where data could be entered manually by the doctors and the nurses whenever they would have time. So all this data was getting fed in. So the advantage was that any existing patient monitor or ventilator could be connected to these IoT devices. And these data were then thrown into the cloud. And this data was accessible to the remote setups like us. And our basic aim was to see how much we could support these patients and their doctors and their NICUs without adding too much cost to them. So most of the times it was through high-end camera monitoring and electronic data record monitoring during real time. So this is a district hospital in UP. It's a very, very busy NICU unit at about 20 to 25 babies all the time, very sick. You can see that we had put in high definition cameras right in the center. It could monitor and turn around and see very, very close. We could even see the pupillary reaction of babies with these high definition cameras. And one camera was suitable for babies, about 5 babies at a time, who were kept in the NICU cots. We had a nursing station there itself, also equipped with a webcam and a microphone and to connect with our 24/7 remote center. And all the time at our remote center, which is called the hub, we had a doctor and a NICU trained nurse all the time available for clinical support and watching these babies through the camera and having access to the electronic medical records like you can see. It was a kind of a platform which was made specifically for this program, and we could get almost all the data from the babies directly from their monitors, including minute-to-minute recordings of their heart rates, respiratory rates, saturations, manually, of course, entered blood pressure records, as well as the manually entered data from the doctors, which, of course, over a period of time, we started trying to make it even easy to have templates made for patients, standard discharge summaries, standard admission notes, all this we were able to help the peripheral doctor do so that his work became easy and he could concentrate more on doing procedures and looking after the babies more clinically. So it was like a kind of advantage to the peripheral unit that they could look after their babies much more effectively, and probably they felt better because the time was saved and all the menial tasks, especially of data recording or manually entering, all that became easier. Sometimes even the remote team from our side would enter the data for them, so that their tasks became very simpler. Especially in units like this in UP, it was a very busy unit and they really appreciated the service. So this is the typical monitor screen, which you can see. The screen capture shows the data all the time. For example, even if a child is on ventilator, the FiO2 all the time, the PEEP, this is all directly derived data from the ventilator. Now data, like all this equipment is available now, which can directly talk to the different types of ventilators or the monitors and capture the data directly. Earlier, when we started the service, it was initially manual entry of the data, which the doctors and nurses at the periphery had to do. But then later, certain technology companies were involved and they could do this directly. And all this is now available. This is again 24/7. We gave them a service of a mobile handphone. Both the doctor at the periphery and the doctors in the remote center were able to access the data on their mobile through a mobile app 24/7. And through the app itself, we could talk to the doctor and explain to them. We could do a video call with the doctor or the patient, and we could see the nurse examining the patient or showing the babies to us. So this kind of an app development has also helped in remote monitoring. Now, point of care assessment tools have also helped us a lot. In fact, the peripheral unit in UP, we requested them to get an iStat machine, which could help doing arterialized capillary blood gases. Of course, in trying to install such hub and spoke models, there's a lot of training required. So initially our team went away to the place called Gorakhpur, which is in northern UP, and we had to train the staff to use these point of care devices effectively. They didn't have the facilities for capillary blood gases. We got that introduced, and they were able to then relay the data most of the times. Recent machines, of course, have come where the incubators can talk to us. They have enough sensors to relay all kinds of data about the temperature and the humidity and oxygen levels. These are all the new things which are now happening. Of course, physician-based lung ultrasound, screening echoes is all going to happen. So in a higher end unit where we were monitoring, where the physicians were very capable of doing ultrasound and echo, we could even see the echo images and we could interpret them and give them guidance as to what to do next. Of course, blood gases, capillary gases we went on to as much non-invasive monitoring as possible. So oxygen saturation index, we had published earlier some work on oxygen saturation index. We also now recently, as Dr. Soni was talking about perfusion index, been using a lot of perfusion index in the assessment of fluid status and perfusion status in babies. And recently we had the 2 publications from our NICU where we have been using plethysmograph variability index to determine whether the baby needs fluids, especially in early shock, or whether the baby is fluid responsive, and whether there is any, especially with comparison to the inferior vena cava index, we have done some studies which shows that the simple readout from the pulse oximeter, especially the Massimo pulse oximeters, you can get the PVI directly or the PI directly, that can give us some status. So I think the future to go would be to use all these non-invasive indices to see and assess the baby remotely and trying to see whether we can give better guidance to the patient. Apart from that, of course, images are directly loaded onto these systems. These electronic health records have the ability to directly transmit the data to the remote unit, and we can easily look at these X-rays directly and give them guidance. This is all now possible in today's age. So, for example, this was a case, a child who was very sick, ventilated, RDS, hyaline membrane disease, PPH, and sepsis, and initially CPAP. We could, now mind you, this particular pediatrician was a DCH pediatrician. He had not been doing too much of neonatology before we started helping him. And you can see that slowly we were able to help him. The child went on to invasive ventilation. But of course, it's very important to realize that the clinical procedures is something we have to make sure in the remote unit, doctors and nurses are able to do it effectively. If the child needs to be intubated, obviously in remote monitoring, you can't help them, but you have to see and hope that they are able to intubate babies well. At least the procedural skills should be very good. Many a times that is where is the biggest challenge in our country. But of course, drugs, inotropes, antibiotics, aseptic protocols, monitoring the baby round the clock, critical care monitoring, all this had helped the child and the baby survive well. The other child, classically, we had a child who was, as you can see in the peripheral units in districts like Bijapur, they use sometimes only head box oxygen. They don't necessarily use high flow nasal cannulas or CPAP, but nevertheless, this baby went on to non-invasive ventilation. We spotted a pneumothorax on one of the routine x-rays, and we requested the doctor to put in a chest tube. He was very reluctant, but then finally, under our guidance, he could do that, and the child subsequently got better. We also had other high-end ventilators available in many units. Now, the biggest advantage in this country is because of the NHM project and many peripheral private NICUs available in the country, the access to high-end equipment is there. The biggest challenge is manpower and trained manpower. And of course, clinical decision supports. Clinical decision making becomes a challenge. And that is where senior neonatologists like us, many of us, and even the young DMs and the qualified neonatologists in the medical colleges, they can help babies survive better. This baby was brought in gasping, had to be ventilated, actively resuscitated as per. We were watching the child being resuscitated, and we could tell the doctor what needs to be done. And subsequently, the child was very sick, and we collected, including the electrolyte abnormalities we could do, gave him advice on inotropes, and the child subsequently recovered well and did well. We could also help babies to be picked up. For example, this baby who was remotely transported to SGPGI for cardiac surgery, we could help pick up critical care heart disease just on a routine echo. He didn't know how to do a functional echo at the bedside, but there was an echo machine available in the hospital, but a cardiologist was not available. We could actually read the echo for him, and we could then help him get the baby transported remotely. We monitored the baby being transported, and the baby could go to a facility which was 3 hours away, the teaching hospital, where the child underwent cardiac surgery. So during this whole plan of about a year and a half, which we did, we were looking at various outcome indicators. Most of the times, apart from structural indicators, improving the nurse-patient ratio, trying to teach and improve the quality of care, we also looked at outcome indicators, like in the remote district hospital in Gorakhpur, the all-cause mortality reduced by about 28%. The incidence of CLAPC, we were able to look at it. A lot of process indicators, we were also monitoring it. And there are multitude of these things that can be monitored, at least as research or as quality care, to see how best we can do for these babies. We are still in kind of a very, I would say, infant stage for trying to see how remote monitoring and remote tele-NICUs can improve outcomes. But nevertheless, we felt that using this specific model, where we did it for 2 remote units in UP, I could approach the Karnataka government in India, and we did a pilot project for a tele-NICU. Karnataka is a state where the gap between the haves and the have-nots is very high. So the urban mortality rate for newborns is only 8, and the rural is about 16. And it's quite a challenge. Therefore, overall is about 16, and the rural is about 20. So it's quite a challenge to look after babies, especially in the taluk hospitals and the remote district hospitals. So we had therefore approached the government to see how best we can effectively use tele-NICU services and see how to help these babies better using a tech platform and using the resources whatever they had. So in this setup, like I spoke earlier, we had already some of the units had a standard ventilator, like the Hamilton ventilator is what most of the units were using in the district hospitals. And we had the old BPL monitors which are there with the patients, but we could somehow find some technology to connect them up to the servers and remotely monitor them. Of course, in certain units, we were able to fix newer monitors, and the ventilator and the patient monitors could speak to our IoT devices, and we had audiovisual cameras also set up, and point of care input was done and the bedside by the nursing staff and the doctors. And we had the advantage that a lot of neonatal colleagues, especially from the government sector in the teaching hospital called Indira Gandhi Institute of Child Health in Bangalore, they were able to help us, and we created a neonatal expert. It was not a standard kind of command center room. We had the mobile devices being used by all the doctors, and all the data was going to their mobile. So any pediatric neonatal doctor was available, was able to monitor the babies both by audiovisual means and looking at the data, and they could actually interpret it and help. So we made a roster of all the doctors, and we were able to service the district hospital. And therefore, we found that there was a good kind of, I'll probably cut it short here. Basically, we got a good kind of output from the district hospitals, and to a large extent, we are able to show to the government of Karnataka that we have been able to help the improvement in the morbidity and mortality. So this is a project which we have now tried to request the government of Karnataka to spread it to all the main districts of Karnataka, and including all the taluka hospitals. Technology coming to this help, along with almost voluntary services by the trained neonatologists in the government sector and in the private sector, is what we are envisioning. We are of course looking for more funding for improving and trying to upgrade this technology. And it is like a Uber model, which I am trying to see how we can effectively use. I'm sure in a city like Bangalore, at least there will be at least 20 neonatologists willing to provide this service, and timings can be given. Each neonatologist, a young one also, can provide care to nearly about 50 babies at any time using this technology. And anybody who's free can join the system, and we therefore are trying to roster all doctors and trying to see how much more clinical care they can give it remotely. And this is probably going to be at the very peripheral level being implemented by the ASHA workers also, where we are trying to develop a monitoring app for them. So while this all was going on, I had the opportunity to read this paper from the Pediatric American Societies, which was early detection of late onset sepsis and NEC using AI. And along the same time, we have been discussing about the hero monitoring, as Dr. Soni spoke about it earlier. So I had the fortune to discuss this with Dr. David, who's from Antwerp in Belgium, who's developed a fairly robust AI model for detecting sepsis. Probably the best thing would be to validate this, though we unofficially validated this in some patients, but research is going on in this sector, and I'm sure we're going to get alerts very soon about how to predict AI, and especially in remote monitoring, AI definitely is going to help, especially in picking up sepsis. So I now move on to the eNICU project briefly, which Dr. Sanjay Wazir, my friend from Motherhood Hospital in Gurgaon, has done. He's done a much more kind of wider use of teleNICU. He has covered close to 7,000 odd patients, 7,000 odd patient days in a 2-year period. And his key performance index analysis has been fantastic. He's looked at the discharge to readmission days, transfer rates, and mortality rates have substantially decreased by almost 80% in the units he has been monitoring in the areas like Hisar and many smaller towns in Haryana around his place where he works in Motherhood Hospital, and he and his team has been doing. And their plan for the future is to see how to get into predictive analytics, as what we have been discussing. They've been trying to expand their resource availability and continuous training they're planning to do. So with this, probably I'll try to just move on to a little bit to yesterday what we discussed. So we also found that the biggest gap is between the baby who's stable in the peripheral unit and needs to come to a higher center, either for cardiac or for the care for the baby. The gap is to stabilize this baby properly and to bring the baby back stably. So we realized that neonatal transport is very important, and all hospitals, even in cities like Bangalore, they're all doing anecdotally transports on their own, but it's not as if a unified effort. So in Manipal hospitals in Bangalore, we have 10 Manipal hospitals now in Bangalore. So last year, we created a unique centrally monitored and operated transport network. And subsequent to that, we have been running it quite efficaciously. It has basically created a good infrastructure with state-of-the-art ambulances and remote monitoring. And we have a centralized helpline. So this is how it works. The centralized helpline numbers are shown there. Anybody can call, including patients or including doctors, pediatricians. It is not only for Manipal hospitals. Any hospitals can take this service. So the call is then sent to one of the centralized doctors who's manning the call, who takes all the details and the demographics, liaisons with the coordinator, and then determines the level of NICU support the baby needs. And the baby and the team therefore goes to the baby, the team nearest the baby. From all the 10 Manipal hospitals, all the people have been trained. There are transport ambulances and transport incubators and ventilators available with remote monitoring facilities. The nearest team goes to fetch the baby and retrieve the baby stably after stabilizing. So this has been working fairly well, and we hope more and more people use this dedicated neonatal retrieval service. We have a iSciences remote monitoring system. The baby's got some wireless sensor stuck onto his chest. From there, we can actually monitor, and especially in long transports where babies we pick up from towns about 4 or 5 hours away, constant monitoring is happening, and we have a centralized helpline so that the transporting team also is all the time connected to us. So this is a service which we had the occasion to publish it recently about, and this improved the quality of the service transport. So we found that the child arrived better with less of hypoxia, less of hypoglycemia, less of acidosis, and the survival rates also have improved quite a lot. And I think this is the way to go, to see if every small town or every large city also can develop a good transport network just on the lines of the Western countries and see how best to look after our babies betterly. So this is the motto which we have been trying to see, NICU on wheels, and trying to bridge the gap between the referring hospital and the tertiary care center. So thank you so much, and it will be such a pleasure to take any questions if there are any. Thank you so much, Dr. Kiran More, for giving me this opportunity, and Shamla. Thank you so much.
Thank you, sir. Excellent talk. I think the great idea of connecting every gap. I mean, you've closed every gap in neonatal care, right from where the baby is born and then the transport. Everything seems seamless. I think points where we actually have problems with outcomes is when they're born in a peripheral center, we're not able to transport fast. The care at the birth center is not optimal. I think you've closed all the gaps, and it's an excellent idea and excellent how you people have put it into action and seen outcomes.
Thank you.
Sir, I have just 2 questions. What was the cost of setting up this tele-NICU in one, if you have to connect one hospital to one hospital?
Yeah. So I had worked with a company which is for-profit company, and I was their advisor at that time. And it was naturally a company trying to build a service mostly for adult ICUs, but I requested them to let's initiate this program for the neonatal units as well. So it is a kind of subsidized model because the company itself, most of their profit comes from adult ICU cases. They are a large presence in the adult ICU telemonitoring systems. So our units in Gorakhpur, and now we are doing a project in Bahraich also. Now totally about 100 to 120 babies are being monitored at any time. It's very, very subsidized. Obviously for a newborn unit, it has to be subsidized. But for the adult unit, the charge of monitoring a patient plus a 24/7 monitoring plus also the platform service, it comes to about 1,500 rupees to 2,000 rupees a day. So many peripheral hospitals with the private setups have opted for the system because finding doctors 24/7 to be on site and qualified at that and to be able to take clinical decisions is becoming challenging. So you may have a very good neonatologist who's done his DM or something and comes to work in a peripheral place, but he finds it challenging to closely monitor and take decisions, especially at night. So these alerts are something, in fact, recently, one of our very well-known neonatologists in Bareilly is Dr. Ravi Khanna. He uses this service and he finds it very useful. He's got a 30-bed NICU, very busy, and he's alone sitting in the OPD, then comes at night up and down here and there. Challenge is to find duty doctors who are qualified and trained enough, and this service has found it very useful. In the government sector, the challenge is the cost still, because as a pilot project, the government could give us funding for that. I have written to UNICEF now, especially in fact, Dr. Kiran More knows, we wrote to UNICEF when he was heading the unit at Wadia Children's Hospital. They have still not got back to me. I spoke to Professor Simini Rani just a couple of days ago. She says the UNICEF in Maharashtra is struggling to find funding, but we have to look at it. And also we have to see how best to subsidize it through CSR funding. So the government of Karnataka is trying to get some kind of subsidy for this. It's going to be a
So
challenge. Finding funding is a challenge.
on that note, I will just like to share that at MRR we set up our command center now. So in fact, it's all ready to live in 2-3 months. All the monitoring facilities and ability to connect remote centers now. So maybe again we can reconnect because I think the challenge was technology and the resources, manpower, and also as you said, funding. And you need a team actually to support this. So currently at MRR we could do this. So we are just testing the systems within the hospital right now, and in 2-3 months probably will be live. At least the technology is there now. But it
Just
was
one
very
question
inspiring.
there on the chat.
Yes, Siddharth, yeah.
Sorry.
Yeah, no, take the question. Yeah,
No,
medical legal
just a
aspect.
question, the medical legal aspects of tele-NICU in India.
So the medical legal kind of responsibility is still the peripheral doctor's responsibility. He is the one the child has got admitted under. We have looked at it very carefully. We have a physician to physician engagement here. The tele-NICU service is going to provide advisory facility to the physician who is looking after the child. Medico legally, he is only responsible. The tele-NICU company will probably absolve itself of any responsibility to this. So it's a hospital, it's a kind of tele-NICU, which is basically advising the hospital or the doctor. So it's a MOU between them. So I don't think the hub needs to be worried about, or hub doctor. That's why in this government program, the hub doctors have freely volunteered their time and their services, so that they don't feel they feel it's a good service to do. So we just have given a platform. Hopefully, more and more such platforms that are available, some of us can spare more time to do this voluntary work.
Thank you, sir. So one more thing, do they become more complacent, the peripheral units? Do you see problems when they do? No?
No, it's the other way around. Actually, I must tell you some couple of instances. See, because we are monitoring the babies more closely and we are finding problems and we feel this should be done or that should be done, or let's say there was a doctor who at 3 in the morning we said, our nurses pointed out, then I was called, I also saw that the baby's things were getting worse and the child actually needed to be intubated and ventilated. So the doctor who was a consultant was not responding, and I had to call him directly. And he was very reticent about it and said, "Why are you disturbing me? I'll go and see the child in the morning." So, but that is the unfortunate thing, because you see, that is the issue which we have to set it right in the beginning. So when we go and look at a neonatal unit to do tele-NICU services, we have to see the facilities it has and the level of care it can deliver, and also look at the qualifications and the capability and the skills of the pediatrician who's going to look after. Then there has to be a good communication and a good buy-in from the pediatrician at the peripheral side. So sometimes it's led to animosity where the nurses here are saying, do this to the peripheral nurse. The peripheral nurse is so busy, she says, I cannot do it, or I'm tired. So these things happen. But I think still the doctors and nurses feel it's a great service.
Thank you, sir. Kiran, do you want to wind up?
Yeah, sure. And again, very inspiring. I think you've covered, like literally, as Siddharth said, all the gaps have been breached. All the latest technology, and I know, and I'm always fascinated. All your talks, you always come up with whatever is available in latest in the market in the technology. I think you've already used it. Even we start about thinking about it, you have already utilized it. So that was again inspiring. A lot to learn from you, and
Thank
definitely
you.
we'll connect
That was a
offline.
great topic. Yeah.
Yeah. Thank you
Thank you.
again, sir.
Thank you so much.
So
Yeah.
thank you. So that comes to the end of today's session. Thank you. And we have almost 130, 40 people staying till end. So yeah, it was really informative. So I thank everyone who participated. Thank you all the faculties and all the core faculties who are helping me to build this workshop. And we hope to see a few more people. Almost there are many coming for a hands-on workshop where we will be summarizing this, and there are stations talking from our labor room monitoring. We will be even covering CTG monitoring, labor room monitoring at the birth. We will be talking about intra-abdominal pressure monitoring, ICP monitoring, non-invasive cardiac output monitor, and then EEG and monitoring during cooling, monitoring during transport. So lots of workstations we have created with most of the devices. So those who are interested, please register. Still few spots are left for the hands-on workshop. And I think it was a good marathon of lectures we had in last couple of days. So I thank everyone who attended. We had almost 260, 270 people attending yesterday and 192 to probably max we attended today. So I think it was a good support we got from many people who are interested, and great faculties, great talks. So with that, I thank everyone and all the delegates and attendees for patient listening and asking nice questions and making it more interactive. And thank you again, NNF scientific committee who actually came up with this idea of creating this workshop. So again, thank you from them to give us opportunity from all the core team to create such workshop. And again, thank you, Karthik sir. Thank you again and
Thank you. No, thank you.
staying till late and allowing
Thank
me
you.
to. Okay, thank you everyone and good night.
Thank you. Good
Have
night.
the recording. I will try to see if we can release some of this talk. We'll talk to every faculty in person, and some of the sessions might be released online if possible. Okay, thank you. Thank you
Thank you.
everyone, and we end the session today. Good night. Thank you.